Evening, all respected seniors, dear colleagues, and friends. On behalf of Thane Anesthesia Society, I say Thane. It gives me an immense pleasure to invite you all to today's academic webinar, and my heartfelt gratitude to the SAM's office bearers for gracing us with their presence. As Honorary Secretary of ISA, Thane, I am truly delighted to see an overwhelming response of 200 delegates who are participating and who will participate. Your presence reflects our shared commitment to continuous learning and excellence in anesthesia practice. Today's theme focuses on two extremely relevant and evolving areas in our day to day practice: cochlear implant and cardiac implantable devices. With rapid technological advances, anesthesiologists are increasingly encountering the patients with sophisticated implantable devices. Understanding their functioning, perioperative implications, and troubleshooting is no longer an option, but it is essential. We are privileged to have a panel of esteemed speakers with us today. Dr. Pradeep Uppal will enlighten us on cochlear implantation, know how for an anesthesiologist, giving us practical perspective on this specialized surgery. Dr. Prajakta More will discuss on anesthesia for cochlear implant surgery, focusing on perioperative management and key anesthetic considerations. Dr. Joy Shankar Jana will address on an important scenario: anesthesia in a patient with cochlear implant for for other surgery, helping us navigate all the challenges beyond implant surgery itself. Dr. Samrat Madnaik will guide us through my patient has pacemaker. What do I need to know? A topic every practicing anesthesiologist encounters frequently in today's era. I am confident that today's session will be highly informative, clinically relevant, and practically applicable to our everyday practice. We will have session of question and answers at the end of each talk to ensure active participation and meaningful discussion. Let us make the most of today's evening. So, without further ado, I invite our moderator for the first session, Dr. Sonali Saraf, to introduce our distinguished speaker and guide us through the academic deliberations. Over to you, Sonali. You are not audible.
Thanks, Yatin, and thank you, Thane Anesthesia Society, for making this interesting webinar happen. This all started with a query from Dr. Manisha and quick response by Dr. Joy Shankar Jana, which got us thinking we really don't know how to deal with cochlear implants. So, lot of us are aware about the types of hearing losses, but we really don't know the treatment options for a sensory neural hearing. So if you think of a cochlear implant, many of us think like a black box. It is in front of us. So better let us hear from a boss who is well known for doing cochlear implants. It gives me great pleasure to introduce Dr. Pradeep Uppal, who is the director and the head of the department at ENT surgery at Jupiter Hospital, Thane. Sir is a student of Sion Hospital, LTMMGH, and is a gold medalist at both the MBBS and the MS surgery levels. He is a pioneer of cochlear implant program in Thane district and conducts regular workshops on on cochlear implant surgery on inviting people or the national ENT surgeons to come to the hospital and do the bone dissections. So he is a great teacher as well. And this program is held at Jupiter 2 to 3 times a year. Um, he has done approximately over 350 cochlear transplant surgeries and is also featured in Limca Book of Records for operating on a 21 day old infant with orbital cellulitis following a sinusitis. He has papers in many national and international journals and is an editor of the textbook chapters of many textbook chapters in ENT. His motto is everybody should hear, whatever the age. So over to you, Uppal sir, for introducing us to this black box, the cochlear implant.
Thank you, Sonali. Thank you for the kind words. Thank you, Thane Society of Anesthetists and Sam for giving me this opportunity. I'll be putting on a mic now, so I won't be able to hear you. In case if there's anything, please show the hand. I'll take out the mic. Now, what do? I share the screen, right?
Yes, sir. The questions are welcome in a chat box. You can just put it in the chat box. We can ask sir at the end of the surgery. Yes, sir, we can see it.
It started?
Yes, sir.
Okay. Well, friends, once very much. I assure you, I'm not going to talk anything theoretical or hi-fi that you will feel why is boring us. I'll talk some practical things. I'll let you know at the end of the session, I'm sure you will know more about the cochlear implant than an average ENT surgeon. You see, we were going to cover, this will be the structure of my talk. We'll talk about who are the candidates, what is normal hearing, what is implant, some steps, challenges, and I want to talk to you beyond cochlear implant, what we are thinking. Now, who are the right candidate? Children who are born with the hearing loss are the ideal candidate whom we should do a cochlear implant. But equally, it's important for the adult who lose their hearing in due course of time. That means they have a normal hearing, but for some reason, whether it's a senile deafness or whether it's due to disease or some drugs, where no hearing aid is helping, in those cases, one can go for or one should do cochlear implant. And as Sonali said, it is only for the inner ear damage or sensory neural hearing loss. It's not for the conductive deafness. The incidence of hearing loss in a newborn baby is 2 to 3 per thousand. You must be wondering, it's such a tiny number. It's not a big deal. But in our own country, every year there are 17.6 million births. Out of that, 70,000 babies are born with the hearing loss. And roughly around 3 to 3,500 children, they undergo cochlear implant surgery. Why so less children undergo cochlear implant surgery? The biggest factor is the cost factor. But other important factor is lack of awareness in the society, with the government agencies, even the doctors, they don't know much about the cochlear implant. When I say the incidence is 2 to 3 per thousand, this is for the normal babies. But there is a high-risk babies. These are the high-risk babies where the incidence of hearing loss is 10 times more. Before we go further, we'll talk about what is a normal ear. And please bear with me. I know you all are aware about it. I'll go to the pointer, laser pointer. So this is the outer ear, pinna, eardrum, the middle ear, and inner ear. This is the cochlea. This is a engine. This is the heart of our hearing mechanism. Now, what really happens is, now when I'm speaking to you, the sound is going to your speaker or smartphone or whatever, it is entering your ear in the form of sound waves, in the form of mechanical waves, and they enter the cochlea. Now, inside the cochlea is a transducer which converts the mechanical waves into electrical impulse. As we all know, our brain can interpret only electrical signal, nothing else. So this cochlear role is to convert the sound waves into electrical impulse and send forward. Now, babies who are born with hearing loss have a defective cochlea. Now, this is a nice animation of normal hearing. Sound is going, hitting the tympanic membrane, ossicular chain moves, and in the cochlea there is a fluid. And when the fluid, in the fluid there are hair cells, and when these hair cells moves left and right, there's a polarization and depolarization, and electrical current is produced. This electrical current travel via the nerve to the auditory cortex and we hear. This is a normal hearing. But what happens in the unfortunate babies who are born without hearing? By and large, 99%, they don't have hair cells in the cochlea. That means the sound is going in the ear. The sound mechanical waves are entering the cochlea, but in the cochlea there are no hair cell which can move and create an electrical signal. So we all know about this neural plasticity. Whenever the baby is born with the part of the brain which is pre-programmed, and part of the brain has to be filled with the sense organ. The nature has provided us that this area is for auditory cortex, this area is for visual cortex. Now what happens? For some reason, by the age of 5 years, no sound enters. Either the parents don't know that baby is not hearing, or the parents are aware but they can't do much about it. In those cases, what happens is the auditory cortex is taken over by the visual cortex. Now, after 5 years, whatever you do, you spend millions of rupees, you cannot get back to the normal hearing. And once the hearing loss is suspected, suppose the family doctor or pediatrician or the parents, they feel, oh, my baby is having a hearing problem. What we do is we have a team of audiologists. They do these two type of tests. I'm not going to technical detail, but I want you to understand the one is OAE, that is autoacoustic emission, and is ABR, auditory brain response. As you see in OAE, there is a single probe. It's a screening test which only tells us cochlear hair cells are moving or no. It's a very interesting phenomena in this. You give a sound, the hair cell move, the hair cell gives back the sound, and if the microphone picks up the sound, that means cochlea is functioning. This is a screening test. It takes less than a minute. But if we suspect a hearing loss, then different frequencies are given to the ear, and you could see multiple wires on the baby's or the infant's head on which we can exactly make out how much is the hearing loss and where is the defect. Once we screen everything and come to a conclusion this baby is deaf, and then we say, oh, you will require a cochlear implant surgery. Now, this is what the cochlear implant looks like. This is the outer part which the child wears it, and there is a one part which we operate and insert in the cochlea. Now, if you see, there is an inner part which is under the skin, and the electrodes go in the cochlea. This rests under the skin, and there is a counterpart which with the magnet which sits exactly where the receiver is there. I'll explain you once again. This is, we do a surgery on a day 1. We open the skin, put a receiver, put an electrode in the cochlea. And after 2 weeks, 3 weeks, when the wound heals, when the child is fine, when we feel everything is good, then we give a transmitter and a speech processor. And this transmitter exactly sits where the receiver is there. Now what happens? There's a mic which picks up the sound, goes to speech processor, which analyzes the sound, transmitter transmits into the inner ear, and child can hear. Now this is a very nice animation. You will, sorry, not playing. Okay, fine. So I explained you how that was an animation which shows you the sound is picked up by the microphone. So the sound doesn't go through the drum. Sound goes to the microphone, microphone picks it up, it breaks down into different frequencies, and then each frequency is converted to electrical impulse, and this electrical impulse in turn stimulates the nerve and the sound goes to the cortex. Let's try a luck. No, it's not playing. I don't know. Fine. So before we contemplate surgery, as a surgeon or as an anesthetist, we have got some stressful condition. Most of these children are associated, they have an associated anomalies. They are syndromic children. Even if they are not syndromic, in 20% of the cases, there is some abnormal cochlea. When there is abnormal cochlea, there is a chance of CSF leak and meningitis. Other thing is, when we operate, it's a very tunnel vision. And that's the reason we keep manipulating head from right to left, head low, head high, so that our vision becomes a straight line, which I'll explain you when when I'm going to show you surgical steps. During the surgery, many times we use facial monitor because facial nerve is very close to the cochlea. And sometimes we elicit stapedial reflex, which we can see on the screen. So that's why we request our anesthetist team not to give any paralyzing agent. Vaccination is must. And most important point, if you tell me to what you should carry home is cochlear implant is just the beginning, not the end. After cochlear implant, we have to give 1 to 2 years of therapy for the child to learn to speak. There are a lot of syndromes associated with hearing loss, but one syndrome every anesthetist should be aware about is JNL syndrome. In this case, what happens is there's a prolonged QT interval. With Sonali, we have done one case. We were all stressed out. The reason is we put a cochlear implant so that child can hear. And when this sound enters the child's ear, it acts like a stimulus. And this stimulus itself can give rise to arrhythmia and child can go in arrest. That's the reason we are very, very careful in these cases. Luckily, we have an excellent team, so we could manage very well with the help of our anesthetist. Now, coming to once we decided, yes, everything is fine, we take a fitness and then we decide to go ahead with the surgery. In surgery, there are the simple steps. First is you take a skin and periosteal incision, expose the mastoid. Once you expose the mastoid, from the mastoid you enter the middle ear, and from middle ear you enter the cochlea. It's not Latin. I'll just simplify for you. This is the first step. There's a head end, there's a foot end, there's an ear. This is the area where we take an incision. And once we take an incision, we lift the periosteal flap and come to the mastoid. Now the real work starts. First thing is just an exposure. And once the mastoid is exposed, then we enter the mastoid. Now, if you see the mastoid bone, the challenge is just above this is a middle cranial fossa and just posteriorly is a posterior cranial fossa. So when you want to do a mastoid, you have to be careful that you're not entering the middle cranial fossa and posterior cranial fossa. The whole aim is to put an implant from the mastoid into the cochlea without damaging the eardrum or without damaging the posterior canal wall. So how do we do? To simplify it, think of it, there are three compartments, or you just say like a train, there are three boxes. This is box one is mastoid, which is connected to middle ear and which is connected to the cochlea. We have to put an implant from the mastoid to the middle ear to the cochlea. So this is the mastoid. We make an opening in the mastoid, and now we have to enter the middle ear. Now, where do we enter the middle ear? You have to enter very precisely. You have to make an opening of 3.5 by 1 millimeter. If you make any opening more than that, you will damage the facial nerve or you will damage the other structure. Once you enter the middle ear, then you have to make an opening in the cochlea so that from here we can put an implant. So simple. You open the mastoid. From the mastoid, you go into the middle ear, and from the middle ear, go into the cochlea. They're all three compartments connected to each other. And once inside the cochlea, there are a number of electrodes, and each electrode is capable of stimulating particular nerve. That means particular sound will be stimulated when the particular electrode is activated. For example, if I say Sonali, for so this electrode will be stimulated, E, this electrode will be stimulated. So this is what is the basis of the cochlear implant. And as I've told you, why we keep turning the head again and again, because it's a very tunnel vision. We have to see from here and reach the cochlea. Once we put an electrode, we have to put a receiver somewhere. This transmitter, this receiver, we have to put in the parietal bone under the skin. But if we just put it under the skin, then it will pout out and The children can hit against the wall or some other children can hit them. Nowadays, the technology has changed where they have made thinner and thinner transmitter. So many a time we don't have to drill the machine. Obviously, thinner the transmitter, costlier the implant. Now, I hope this plays. 1 minute. This, okay. No. In the end, Sonali, if possible, I'll try and show the video. There's a nice video of the surgery. I think it was playing during our practical thing. So this is how we do the surgery. After the surgery is done, there's a very interesting part. And what is that part? That is on table, our audiologist test whether the electrode which we have put are working or no. So each electrode is stimulated by giving a current. Other advantage is, suppose we have done a surgery and once the child comes to you, how much current to give to this child so that adequate sound goes in the brain. If we give too much of current, what will happen? The child will not tolerate. If we give too less a current, child won't hear. So in this case, we do NRT by giving a tiny current. And on the computer, they record and keep it for a reference that next time when the child comes for switch on, the terminology is switch on. After 3 weeks, when we put an external mic, that time we set a particular current which will enter the middle ear. No, this video is also not playing. It's okay. So this I was showing to show you this is a stapedial muscle. So every time we give a current, this stapedial muscle contracts. And that's the reason we want our anesthetist friends not to give a paralyzing agent. Oh, it's playing. Please concentrate on this thing. It's a very interesting, if you can see here. Every time the current is given, the stapedial muscle is contracting. What does it mean? It means your electrodes are working. From the 8th nerve, the sound is going into the cortex. And from there, it is coming to the facial nerve and stapedial muscle is twitching. Yeah, this has started working. Interesting. Let me see if... No. Okay, we'll go further. And then after the surgery, all is not done. As I've told you, the therapy is the most important part of it. And after giving a therapy, they speak like a normal children. No, Sonali, we played this thing.
Sir, can you hear me?
Yeah, I can hear you.
Sir, can you try shutting off the laser pointer and see if it plays?
1 minute. Kidhar hai laser pointer? How do I shut? You see? Just 1 minute. I'll see how to.
Yeah. Pointer option, sir.
था ना? Wait.
हाँ था सर. हाँ.
Pointer option. Where is off? किधर है?
Off नहीं है. Hidden or something. Just a trial, sir.
Okay.
Now try.
Namaste. My name is Madhura Kiran Sangre. I am 10 years old. I was operated for cochlear implant at the age of 13 months. Om Bhurvasvaha Tastaviturvarenyam Bhargo Devasthimale Yo Yo Na Prachodayat Guru Brahma Guru Vishnu Guru Devo Maheshwara Guru Saksha Para Brahma Tasmai Shri Gurve Namah. Tasmai Shri Gurve Namah. Thank you.
Now the point is that this girl was operated at the age of 13 months. Now, if this girl would have been operated at the age of 4 years or 5 years, we wouldn't have got such a beautiful speech. If you think of it, same stress, same money, same anesthesia risk, everything is same, but just because of ignorance from society, medical fraternity, family, they come late and we can't do much about it. So now can I try that surgical video now? Let me try. Could you see now? Now see, this is, I want to show you because during surgery, one thing you remember, when I'm doing for the first case, we are not using cautery much because we have got an implant under the skin and we don't want cauterized area to give way later on. Interesting thing is, if we are doing a second year cochlear implant, we never use the monopolar cautery at all. So what, after taking a skin incision, now what we are doing is we are opening a mastoid. And once we open the mastoid, we make an adequate opening so that you don't enter the middle cranial fossa or you don't enter the posterior cranial fossa. Once mastoid is entered, our second job is to enter the middle ear. Now from here, we are going to enter the middle ear. This pink line is the facial nerve. This burr size is 1 millimeter. So we have to make a small window, small tunnel, so that through the tunnel, our implant can enter. And now could you see the round window membrane from here? That is a cochlea. But before I put an implant, I have to make a well for the transmitter. And once I make a well for the transmitter and we make a channel for, we make an opening for a channel. This is a silicon template which tells us, yes, we are doing a proper dissection, not less, not more. And through here, through the tunnel, the channel will come and the electrode is inserted. Now I'm making an opening in the cochlea. This is 0.6 to 0.8 millimeter opening. So now we have got 3 compartments open, the mastoid, the middle ear, and the cochlea. Then you take an implant and put in the cochlea. Implants are very, very thin. It's like threading a needle, but only thing is here is it's such a tiny opening through which we have to thread the electrode. If you struggle too much, you can damage the electrode. And once the electrode is in, next I showed you about the NRT. Okay, now the challenge is, as an anesthetist, if you happen to do a cochlear implant, only you have to look for it, is there an abnormal cochlea? Because in abnormal cochlea, the chances of CSF leak is very high. This is a real size of the cochlea, what you're seeing. I got it 3D printed made. I can put 4 cochlea on my nail. That tiny the cochlea is. Normally, the cochlea is connected by CSF by the very tiny ducts. But if in abnormal cochlea, these ducts are too big. So what happens, as soon as you open the cochlea, the lot of perilymph comes out. If you are unlucky and if there is no modulus, and now when you open the cochlea, you won't believe there's literally a tsunami of CSF. Sometime we have to wait for half an hour for all the CSF to drain before we put a implant in it. So these are the difficult cases. Generally, when I teach, I tell them first 25 cases you should do normal. Don't dare to do a abnormal cochlea. Cochlea is sometimes so porous that when you give stimulus, now this is a child under anesthesia. When NRT was done, I've told you when we do NRT, we give current. So every time the current is given, there is a twitching. So this is a stressful condition because when she grows up, every time somebody calls her Neha, her face will twitch. So of course we manage the case. We are not discussing here, but it was a good thing. Now coming to a CI program, Sonali, I think I've got time now. 15 minutes, I think I've not seen, but I will wrap it up in 5 minutes.
Yes, sir.
This was a CI program. The first implant we done, I think in 13 or 14. Till now, we have done 400 implant. Initially, who doesn't know, in the first about approximately 98 to 100 implant we did in our small nursing home. And then I was lucky we switched over to Jupiter and rest we have done in Jupiter. You see, I was fortunate with the help of Thane Municipal Corporation, who were giving 2.5 lakh rupees to every child. We did a first implant with the TMC help, where the mayor and then Municipal Commissioner Shri Jaiswal had come just to see if everything is good. By that, we have done plenty of implant and we thought we are happy. But if you retrospectively, if you do introspection, we were really not happy. Why we were not happy? Because these children come very late. In world over, deafness is detected at the age of 6 months, and within 1 year before their first birthday, cochlear implant is done. In our country, we do at 3 to 4 years. Frustration is we take same risk, same money, everything same, but the result are not that great. What result I showed you was a 13-month-old child. But 3 year, 4 year, they speak, they hear, but their speech is not as clear. I was fortunate. The Jupiter Hospital management had a faith in me, and the corporation had believed in me. I convinced both of them that we should start screening these children early. Because even if we are doing implant, we are not getting good result. And this then Municipal Commissioner Shri Abhijit Bangar and our CEO Ankit Thakkar and myself, we decided to screen every child in a government hospital. Private hospital, we cannot dictate to them. So what we took is we took all the maternity homes and Kalwa hospital, took over all this hospital, and we started doing the screening. Not only we screen the children who requires higher testing were called to the Jupiter and we do free testing. Out of that, we picked up 3 children and within 1 year, we operated on them free of cost. Free of cost, we are not doing. Thane Municipal Corporation is helping me. These are all municipal commissioners and the collectors from Thane district MMRD area. I was lucky, I was blessed. I spoke to them and explained them how important it is. My only point was these are the children whom we cannot blame. The heart attack, the kidney and heart, whatever, some fault is of the patient, whether diet or lifestyle, but these babies are innocent. We should help them. Then I was given an instruction that you sit with the dean of the medical college, commissioner, health officer, and formulate an SOP. We made an SOP, and now every child is given free implant. This is something unheard of. Thane Municipal Corporation gives free implant to every child, and we do free at Jupiter Hospital. Very interesting thing came in one of the meeting. This commissioner was very smart. He said, Doctor, there are 6 families who have taken this funds twice. So that means that both children were affected. Why can't we pick up early? Frankly, by that time, even I had not given it too much of thought to it. But when I dived deep, I found, yes, we should do genetic testing for all these children. And now we are doing, with the help of philanthropists, free genetic testing for all the children born with hearing loss. The point is, if the first child is deaf, I think it is a duty to tell them what is the success, what is the second child, will be deaf or no. It's up to the parents whether to continue pregnancy or not to continue pregnancy. Today, we are doing this genetic testing free. We have already got a very good data. Shortly, we will be presenting some very interesting facts. Gene therapy, you have heard of, a lot of media coverage was there. But just to give you an information, only 1% of the hearing loss cases, gene therapy is helpful. All genetic defect, there's a structural anomaly. That means hair cells is not there, basilar memory is not there. But in one gene defect, that is autofurlin, everything is normal, only the stimulus is not dropping from hair to the dendrite. And in these, when we give gene therapy, the child can hear like a normal children. Not come in our country, but I hope shortly it will come. We are in touch with the big players. The future, and I'm sure it will work. All this, brain diseases, Alzheimer's and dementia and all, they're drug-eluting cochlear implant. That means we know that we cannot inject the drug in the CSF. It's very difficult. But through the cochlea, if we put a drug-eluting implant, which will keep sending the drug to the cerebrospinal fluid. It is still in an experimental stage, but one day it will come. Just wanted to inform you. Lot of recognition we received because of cochlear implant, thanks to the society, thanks to the medical fraternity. But biggest satisfaction was this. This girl I operated in 2010, Sanvi. In 2022, she stood second or third in her school. And in 2024, she entered Indian Institute of Technology, Bombay. It was the greatest satisfaction for me in person and to my whole team. Their mother and daughter, they came to thank me. It was really very, very, this is a very rewarding for me. All our children are doing extremely well. They dance, they play, they are like a normal children. But in spite of this, is our job done? Not really, because these children will outlive us. Today I'm 65. Maybe if God is kind, I will working for another 5, 10 years. But these children are 3 years, 4 years. They will live for another 60 years, 70 years. So we need people, we need surgeons who will take care of them. And thanks to Jupiter Hospital, we are conducting this workshop very regularly, where we give them a temporal bone, give them a real implant dummy, and tell them to operate there. Not only them, we tie up with Ali Avarjung, we train the audiologist that how to evaluate these children. What next? It's my biggest dream. First time ever I'm discussing on a medical forum. Just like an horoscope, I plan to make a hearoscope. Now, all these children, when they grow up, they're going to get married, and most of them will get married to someone who has got a cochlear implant. So if we can match their genes instead of matching their horoscope, there is a high chance and we can derive the probability that their next generation, whether they'll be deaf or not. We are working on it. We have already have a good data, but that is my ultimate dream, to give this simple hearoscope to all the families who have undergone cochlear implant so they can decide their spouse whenever they grow up. Thank you very much. These children have a lot of hopes from us, and I hope we'll do something good for them. Thank you.
Thank you, sir. That was a superb presentation. And we always end up seeing the children who are, shaved during surgery or for surgery. But seeing so many children at the end of the surgery, it's really gratifying to see their normal faces. Um, I request you to go through the chat box later on for the comments. Just to start the discussion, sir, in which cases is cochlear implant completely contraindicated or will not help?
Basically, if cochlea is not developed, or if nerve is not developed, I told you about abnormal cochlea, but there's certain time the God is very unkind that cochlea is only not there. We cannot do anything about it. I explain the patient many times when they come, na, ki we are fitting a bulb on the holder for your baby. Since the God has not given a holder, I won't be able to do an implant for you. So that is the only absolute contraindication. Otherwise, we can do in every case.
And one more question, sir. What is the role of cochlear implants? Is there any role in adults?
I mentioned we have got 7 cases of adults. There's one doctor from Latur who lost his hearing after meningitis. So we did a cochlear implant and he's back into action and very, very satisfied. You see, adult cochlear implant, the old age, the senile patient, we Indian mentality is, beta mera bhi zindagi ho gayi hai, abhi main kahan kyun karu. Abroad, 80% of the cochlear implant are adult and 20% are children. In our country, 95% are children, for simple reason, they get sympathy, they get funds. If adult someone gives funds, they will also come for cochlear implant. But now more and more people are coming for cochlear implant. Don't think about only old age and senile. There are a lot of poor fellow who get tuberculosis and they take AKT and they get hearing loss. You heard the case of Alka Yagnik. Fortunately, one case, so there's no 1 year. So it's up to her to do the cochlear implant or no. But God forbid if it happens in both years, we'll have to do it.
Any other questions you can put in the chat box. Sir, I request you to stay with us for the next 2 presentations because they are related to the cochlear implant.
Sure.
And I'll hand over to Dr. Supriya for introducing our next speaker.
Thank you very
so
much.
much.
Thank
Sir.
you very much once again.
Yeah, thanks.
Good evening, friends. Our next talk will be on the anesthesia management for the cochlear implant surgery. And Dr. Prajakta More, she is going to take us through the steps. Dr. Prajakta is MD anesthesia and DNB anesthesia. She has done fellowship in pediatric anesthesia. She has special interest in pediatrics, obstetrics, and regional anesthesia. So we welcome Dr. Prajakta. She is currently working as consultant in Jupiter Hospital, Thane. Dr. Prajakta, kindly share your screen so that you can give us a good lecture. Can you share the screen?
I'm already sharing it, ma'am.
Yeah, okay.
So today, shall I start my presentation?
Yeah, please go ahead.
So today I'll be talking about anesthesia for cochlear surgeries. So just an introduction after Uppal sir's presentation. Cochlear implant is an electrical device that is surgically implanted to provide sound for patients with bilateral sensorineural hearing loss. So these are the anesthesia essentials which we need to take into consideration: the pre-op evaluation, our intra-op things which we need to keep in mind, and the post-operative thing. So pre-op evaluation of the congenital anomalies is the main thing. And as the patient comes in OPD to meet us for the first time for the pre-operative evaluation, we need to reduce the anxiety of both the patients and the parents. And our intraoperative considerations are regarding not to so that our anesthesia doesn't interfere with the nerve monitoring or the cochlear implant electrode. And post-operative, we need to manage the post-operative nausea, vomiting, emergence delirium, and good analgesia.
Any problem, Prajakta?
My slides are not moving. So it is indicated in patients with profound sensorineural hearing loss. As Sir had said, it is not for conductive hearing loss, and there should be some residual cochlear functions to be directly stimulated for the cochlear implant to be functional. And it is best done before 24 to 30 months for the benefit of speech development, as it will benefit the patient during his early development and the plasticity, neuroplasticity that is involved. So in our pre-op evaluation, we need to rule out the congenital anomalies and the systemic involvement of this congenital anomalies, which will affect the anesthetic management. These congenital anomalies are also accompanied by dysplasia of temporal bone and cochlea, which is not only challenging for us anesthetists, but it is also challenging for the surgeons, and they will have to modify their surgical techniques accordingly. So screening for the congenital anomalies is must. And 50% of these cases are mostly because of the perinatal infections, mainly the torch organisms. As we can see in this slide, it is the prenatal detection, it is possible, and this will avoid the further condition of the patient. And these are the congenital anomalies and their anesthetic implications. So Treacher Collins syndrome, which has facial dysplasia associated, which can lead to difficult airway management. Klippel-Fill syndrome, in which there is fusion of the cervical vertebrae, which leads to restricted neck movements, and the extension won't be possible, so difficult intubation. Pendred syndrome, which is associated with metabolic derangements involving goiter and hypothyroidism, Alport syndrome, which is associated with renal and endocrine abnormalities, and as Sir has discussed before, JLN syndrome, which will have prolonged QT interval, risk of ventricular arrhythmias. So these are the other syndromes which are important. Usher syndrome, which is associated with congenital cataract, and one of the points to be kept in mind is to treat the congenital cataract before going for cochlear implant surgery, as if the patient is benefited with the sight, it will the rehabilitation of the patient will be more better once the sight is managed, and then the auditory part is to be managed. Next is Treacher-Collins syndrome, associated with difficult airway, Klippel-Fill syndrome with fused cervical vertebrae, Alport with renal failure, Pendret with goiter and metabolic disorders. And this is a slide with anesthetic implications and the syndromes associated. And one of the main thing is JLN syndrome, that is Yarville-Lang-Nielsen syndrome, in which the patient will come to us with a history of syncopal attacks, fits, and the patient will give a history of sudden cardiac death in one of his siblings. There will be a history of syncope or a diagnosis of epilepsy is suspicious. And on further investigation, there will be prolonged QT interval in this patient, at least 500 milliseconds of the QT interval, and it will be associated with ventricular arrhythmias. This patient, they might also come with automatic pacemaker and defibrillator. So not only important from anesthetic point of view, but these syndromes are also associated with dysplasia of temporal bones, and which may necessitate change of technique of cochlear implant. So in preoperative evaluation, one of the main part is good communication with the patient and as well as the parents. So history taken and communication is difficult as there is considerable degree of hearing loss. We need to build a good rapport with the patient and the parents. If the patient has previous hearing aids, that patient should put that on. The history should be taken and communication with the patient should be done in a low ambient noise. Positioning oneself to the better ear of the patient is necessary. And mask wearing, it might hamper the lip reading if it is possible in the child. So it can be avoided. And the next is the thorough preoperative evaluation, in which we look for delayed milestones, airway examination, and all the, as we have seen many syndromes associated with it, the cardiorespiratory issues, and to quantify the risk factors. And the main point, to build a good rapport with the child and the parents, and to identify the IV access sites preoperatively while taking the history simultaneously, and rule out any active respiratory infections which are present with the ear, which are associated with the auditory symptoms as well. And then one more important thing to be noted is the vaccination status of the patient, especially pneumococcal vaccination, as there are chances of meningitis. It is one of the complications of cochlear implant, and to prevent that, pneumococcal vaccination should be up to date. And our relevant investigations are CBC, urine routine, chest X-ray, ECG, as we had seen one of the syndrome in which it has its implication. So ECG is one thing we need to keep in mind. The temporal, from ENT point of view, the temporal bone X-ray and MRI, these are the investigations which we need to keep in mind. And then the choice of anesthesia, as it can be local anesthesia when it is performed in adult or cooperative patient with mild sedation. And in general anesthesia for our pediatric patients, long duration surgery, and general anesthesia is usually preferred because it is a microscopic surgery and slight movement can lead to damage. So working on ground, these are the specific or unique room setup requirements which are necessary. So for airway, the extension of the breathing circuit should be kept in mind as we turn the bed 90 to 180 degrees. And the decision regarding the supraglottic airway or endotracheal tube is to be made, and endotracheal tube is preferred as there will be positioning of the head, the movement of the table, and there are chances of kinking of the endotracheal tube. So endotracheal tube is preferred over supraglottic airway devices. And it is placed on the opposite side of the site on which the cochlear implant is done for good ergonomics and to avoid kinking and to facilitate good surgical as well as anesthetic conditions. And oral RAE is one of the options of placing it on one side. Another thing to keep in mind is to anticipate the 180-degree turning of the operative room. The head will be turned on one side of the operative side. So you won't have any immediate access to the airway. So endotracheal tube should be preferred over the laryngeal mask airway or supraglottic airway devices. And place the blood pressure cuff on the contralateral side of the operation or lower extremities to avoid surgeon interference with the cuff. And we also prefer the IV side to be taken on the opposite side of the cochlear implant side for the same reason, to avoid surgeon interference. Consider eye goggles for patient eye protection. Double stab the patient to ensure no patient movement with potential for extreme bed conditions, as the table is moved, it is tilted on right or left side, or a reverse Trendelenburg position is given. So a double stab of the patient is done to ensure no patient movement. And now the conduct of anesthesia. The takeoff is with smooth induction, a good plan of anesthesia, enabling the good surgical field, especially for as it is an ENT case, and to enable the testing of neuromuscular condition by avoiding muscle relaxant. And we need to time the relaxant well, and we need to recognize the complications, which we'll be discussing further. And with smooth induction, a takeoff, there should be smooth reversal and extubation for landing. So how we do it? We pre-medicate the child. Benzodiazepines are preferred. If the child has no IV access, we can give oral pre-medication or nasal pre-medication, and we need a time period of 15 minutes at least for the pre-medication to act in the recovery room, in the pre-operative room, and all standard monitors are applied: electrocardiogram, blood pressure, pulse oximeter, capnography, agent monitoring, and train of 4 monitoring. And general anesthesia with endotracheal intubation with controlled ventilation is the choice to maintain good hemodynamic conditions of the patient. So how do we conduct the anesthesia? The induction can be IV induction, or it can be an inhalational induction. So tracheal intubation with a single dose intermediate acting neuromuscular blockade is preferred. Quantitative neuromuscular monitoring at the ulnar nerve is done before prior to giving the muscle relaxant, and it is calibrated at induction. Nitrous oxide is avoided for obvious reasons, and total intravenous anesthesia or partial intravenous anesthesia is preferred when we go for checking of the facial nerve. So propofol infusion with 125 to 300 mics per kg per minute infusion is started. Remifentanil 0.05 to 1.3 mics per kg per minute. In so once our induction is done, the antibiotic prophylaxis is given, as it is a foreign body implant to be put. Avoid nitrous oxide. Maintain moderate hypotension. The mean arterial pressure is maintained within 20% of the baseline. Fluid replacement is done by a measured burette set. Pain relief is both via intravenous and via suppository. IV dexamethasone and antiemetic like ondansetron is given to prevent PONV. And once the cochlear implant is put, there is a limit to use the electrocautery. And facial nerve identification and preservation is done by timing our neuromuscular blocking agents. And the analgesia It is given by fentanyl 0.5 to 2 mics per kg, acetaminophen per oral IV or per rectal, ketorolac, and local anesthesia is injected by the surgeon. If no local anesthesia is injected by the surgeon, we anticipate the need for higher doses of opioids. So during the surgery, the intraoperative consideration are the first is the facial nerve preservation. It is identified by electrical stimulation. Thus, we need to avoid the use of muscle relaxant. It should be done after weaning off the effect of the muscle relaxant. And if you are not using any muscle relaxant, total intravenous anesthesia can be maintained throughout the surgery with propofol and remifentanil as discussed previously. Steroids is to be given to prevent edema, and full neuromuscular function is desirable, but small degrees of residual function. It does not affect the facial nerve monitoring. So a starting dose of muscle relaxant can be given during the induction, and in mid-surgery, the facial nerve monitoring can be done without the repeated doses. And as facial nerve functions, it is not affected by small dose of the neuromuscular blockade agents. And these are the electrodes which are placed for facial nerve monitoring. The one on the frontalis muscle, the orbicularis oculi, oris, the masseter, and the ground electrode is placed on the chest. And the fluid management, it is a long duration procedure, but there is no significant blood loss. So avoid giving large amount of fluids as it will lead to bladder distension and post-operative agitation. The fluids requirement is managed by crystalloids for fasting, and the blood losses are replaced. You can usually give 10 ml per kg per hour of the crystalloid fluid. And our next thing to manage is the post-operative nausea and vomiting. As we are dealing with younger patients, long duration of surgery and mastoid drilling, direct vestibular system stimulation, and suction irrigation, which will cause caloric vestibular stimulation. So all these factors lead to nausea, vomiting in these patients. So we need to take prevention to avoid this post-op nausea, vomiting. So these are the risk factors: age below 3 years, family history, and as we are moving below this table, the risk factors, as we can see, those are increasing as we are dealing with a ENT surgery, pediatric child, and long duration surgery. So the risk factors are more and the score is more. So to avoid it, we give IV ondansetron 0.1 to 0.15 milligram per kg. It can be given up to 4 mg. Then intravenous dexamethasone 1 to 1.5 mg per kg. So towards the end of the surgery, the BERA testing is done of the electrode array or electrically evoked stapedius reflexes are done to ensure there is proper functioning of the receiver stimulator. And so towards the end of the surgery, the concentration of the inhalational agent, it is kept at the minimal level, and no significant fluctuation should be there in the carbon dioxide levels to ensure proper not to interfere with the stapedius reflex. And the right intravenous anesthetics should be used. The patient should not be too deep. There should not be too much of hypotension for maintaining the integrity of the periphery auditory pathways and to predict the comfort levels. And post-operative, a chest X-ray is done for assessing the position of the array within the cochlea. So these are the tests which are done: neural response telemetry, stapedius reflex threshold. In our institutes, neural response telemetry is done. So it is least affected by anesthesia. Muscle relaxants are allowed, and it is ideally done intra-op and early post-op. And it will give us the idea about the integrity of the nerve and the cochlear implant. Next is stapedius reflex threshold. in which this reflex is abolished by muscle relaxant, so they are to be avoided. A light general anesthesia or spontaneous respiration is preferred, and it will give us the idea about what level of sound the patient can tolerate. So just before closing the incision, this is how the electrode is placed and the NRT is checked. And once an adequate response is obtained, it is taken for closure. And before the use of electrocautery, it is discouraged once the implant is placed, and a proper hemostasis is to be achieved before device placement because the use of electrocautery is avoided post that. And at the end, we want a smooth recovery of the patient. The patient should not be bucking or cuffing. Consider a deep extubation if the patient is a candidate, and if not a candidate for deep extubation, consider dexmedetomidine to minimize bucking or cuffing on emergence. So a smooth reversal and extubation with the patient in lateral position with adequate pain relief, and monitor the baby in the recovery room or pediatric ICU care if the patient is syndromic associated with systemic illness. And these are the intraoperative surgical complications which we need to deal with. The facial nerve injury, which can be reduced by electromyographic neuromonitoring, and neuromuscular blocking agents and local anesthetics interfere with the signals near mastoid. So no top-up should be given while assessing it, or total intravenous anesthesia is preferred. Next is the lost airway. There is no direct access to the airway. So ensure the airway is well secured before positioning and turning the patient over to the surgical team for prepping. And surgical stimulation, local anesthesia from the surgeon will decrease the amount of anesthetic required, but there might be some patchy areas which may exist, so which would cause sudden unanticipated stimulation. So there will be sudden tachycardia while the surgeon is handling the round window or drilling the bone. So the patient should be made deep, and adequate extra level of anesthesia should be maintained during that time. And the next is dural injury. So mastoid drill can injure the dura, resulting in bleed and CSF leak. So we can help in lowering the CSF pressure by hyperventilating the patient, repairing the defect with tissue and bone wax, administration of mannitol. And if we are giving mannitol, we need to empty the urine post surgery, or at least catheterize the patient. And you can also aid in lowering the CSF pressure by placing the patient in reverse Trendelenburg position. Next is bleeding. So it can be decreased by injecting adrenaline containing local anesthetic. Avoid tracheal ties, extreme lateral rotation of head, excessive fluids. 10-degree reverse Trendelenburg position can be given, which will decrease the bleeding. Usually it is minor unless there is a sigmoid sinus involved or a major emissary vein is involved. And if there is air embolism risk, immediate occlusion with the pressure or saline is done. Turn the patient on the left side, aspirate the embolus, give 100% O2, and keep the patient in Trendelenburg position. These are the post-operative complications: CSF leak, meningitis, facial palsy, device failure, and mild balance problems. So the take-home message is to build a good rapport with the patient preoperatively, ensure appropriate anesthesia techniques, total intravenous anesthesia or modify your anesthesia, consider treatment for post-operative nausea, vomiting, give proper analgesia, and manage the complications and anticipate the complication. Thank you.
Dr. Prajakta, very good presentation. Do we have time to take some questions? Dr. Yatin?
Yeah, we can take it
Okay.
next time.
So there are some questions in chat box. Some are asking whether only spontaneous ventilation has to be done during these cases. I think Dr. Sonali has answered that. Prajakta, what will you suggest?
We prefer controlled ventilation.
Okay. And which is the commonest syndrome, congenital syndrome you have seen for these babies when you have given anesthesia for such cases?
I had seen one case of Klippel-Pill syndrome, but the extension was not that limited, so it was easy to manage.
Okay.
Can I come in?
Yes, sir.
Yeah. So usually we don't go on spontaneous ventilation. It is controlled ventilation with TIVA. And we see to it that the train of 4 is nearly 90 to 100%. So you get a good facial monitoring as well as ESRT, that is the step-aided reflex. And for congenital syndromes, most common is we see the rubella and CMV, that is cytomegalovirus. These are the two commonest torch group of infection leading to bilateral sensorineural deafness and leading to cochlear implants. So you can listen to in my talk. I'll be covering some of them. Of course, Prajakta
Yes,
has
sir.
a fantastic job. She has covered most of them. And I just want to say that we don't use inhalational agents at all. Once the patient is under TIVA, we maintain under TIVA with monitoring of train of 4.
With propofol and remifentanil.
Whatever, you can use fentanyl also, because when remifentanil was not available, we are still using fentanyl. So we can go through it.
And for adult patients, sir, they can be maintained in spontaneous?
Yes, exactly. No, not spontaneous.
Achha.
Even if the train of 4 is you achieve of between 70 to 80%, you can still get a good step-aided reflex and you can monitor the facial nerve. Okay.
Achha, there is one more question. Can we use nerve block along with GA?
Yeah, I'll do. We have done the first case in India when we did a bilateral cochlear implant in an adult lady, 28 years old. She had tuberculosis and she was on multi-resistant drug treatment, and when they had to give aminoglycosides because of the autotoxicity, and she had hardly, both her lungs were fired. I've published this paper, and 25% of the lung was there. The right upper lobe was only there. So she could not even walk even for 3-4 steps. That case, we did a bilateral cochlear implant under local block and without any sedation. I used dexmedetomidine just to keep her quiet. Otherwise, she was so cooperative and so motivated that she didn't move at all. Bilateral we did.
Good. Also, Dr. Pratiksha, which muscle relaxant will you prefer? The first
Yeah,
dose
you can use any. I'm sorry, Pratiksha, you can answer.
No, Prajakta, sorry.
Any intermediate acting muscle relaxant can be used.
So
and only one dose has to be given. After that,
no. I'll tell you. I don't know what Pratiksha does. What we do initially when we used to use vecuronium, and then we shifted to atracurium, etc. You can use any, but main point is train of 4. Before the reflexes are checked, your train of 4 has to be between 70 to 80%. That is it.
I think I will hand over to our next moderator, Dr. Vijay.
Yeah.
Good evening, everyone. I'm audible?
Yes.
Yeah.
Yeah, Vijay, you'll have to allow me to share my presentation.
Yes, sir.
Prajakta, stop sharing.
Yes.
Zala?
Sir, you can.
Yes,
Yes, sir, you can.
Good evening, everyone. And thank you, Thane ISA, for giving me this opportunity to moderate this session. And it's my honor and pleasure to introduce our next speaker, Dr. Jaishankar Jana. He is a very senior anesthesiologist and a pain physician. And he is currently attached to the KEM Hospital Pune and Galaxy Care Hospital Pune. He has award-winning paper on anesthesia for robotic surgery, which is presented in the MISACON and ISACON. He has 4 international publications and 6 national publications. His area of interest are anesthesia for robotics and advanced laparoscopic surgeries, anesthesia for cochlear implants, and anesthesia for kidney, liver, and uterine transplantation. He's been a governing council member of ISA National from period 2016 to 2019, and governing council member of ISA Maharashtra State from period 2012 to 2016. Honorary Secretary of IOA Pune City and Honorary President ISP Pune City. And very interesting, he's the first in India and Asia and for giving an anesthesia for a uterine transplant. And anesthesia first is the system of the uterine transplantation. And I think I read about this case in a newspaper and I was amazed. So our next topic is patient with the cochlear implant for other surgeries. Sir, you can share your PPT.
Yeah, it is the starting of my PPT. Thank you, Dr. Vijay. Thank you, ISA Thane, my seniors and my teachers from ISA Thane, and President Pratna Thakar, Yatin Kharinar, Manjiri Ranade, Priya Joshi, and of course my dear friend Manisha, for allowing me to present this talk in today's ISA Thane. And I thank Dr. Pradeep and Dr. Prajakta. They have practically covered most of the points, and it will make my lecture small. So I want it to be more of an interactive. Put in all the questions, whatever you have in the chat box or when we go for discussion, because it's very important. So it is not rare that a patient who has undergone a cochlear implant in the past and now comes for some other procedure. It could be an emergency procedure or elective procedures. So we'll discuss it, and so I want more discussion on it. It's not going to be very big because most of the points will be overlapping, covered by Dr. Pradeep and Dr. Prajakta. So it was a nice presentation by Prajakta, which has covered a lot of points which I have. So I've been doing cochlear implants since 2006, and over 20 years we have crossed, I think so. I have lost count, I think so, more than 800 plus. I don't know, last count was more than 850. And we are doing unilateral and many bilaterals. So in one setting, we do bilateral cochlear implants who want the bilateral cochlear because it's a costly surgery. And in this last 20 years, I have published 2 international articles in Cochlear Implants International. The first article is Total Intravenous Anesthesia on Intraoperative Monitoring of Cochlear Implantation. What we were talking about, intraop monitoring of facial nerve and ESRT. So we started this monitoring in way back in 2009, and it took me nearly 3 years to publish it. This article was published in 2013. And now I think so all over places who are doing cochlear implant and who do intraop monitoring like NRT and ESRT and ECAPS, they do follow what we are practicing here. So if you want, you can go through this article. It gives a fantastic knowledge about how to do it intraoperatively. The second article which I published was in 2016, which is the first bilateral cochlear implantation under local anesthesia in a young adult. So this was a young lady, which I just told, 28 years old. She lost her hearing because of prolonged aminoglycosides, which was used for MRD treatment for multi-resistant drug treatment for tuberculosis. But she was so motivated that she said that I don't want one, I want to do 2. And this was one of the rare case presentations, and we published it in Cochlear Implant Internationals. Of course, we did we did a poster presentation in the World Congress of Cochlear Implant at Baltimore on the same technique of intravenous intraoperative monitoring of cochlear implant way back in 2012. And this was one article which we have all read. Everybody is scared about. This is our experience of Jervell-Lange-Nielsen syndrome of 4 cases. And all we did was excellent. And after that, this was a publication. After that, another we did 2. And all of them are doing good. So this is a thing which we have to be very careful, very careful when we are managing this case, such like cases. And of course, I don't know if anybody was there in 2011. We had ISACON in Mumbai, and where I presented a paper presentation was done on cochlear implantation in Mumbai. So that was the last time I presented cochlear implantation in Mumbai in 2011. So cochlear implantation, as we have already been hearing to all our speakers, it is done on a patient who has bilateral severe to profound sensory neural deafness, which Dr. Pradeep sir has already mentioned. So when we get a patient who has undergone a cochlear implant, Just think of it, whether the patient has undergone a cochlear implant or whether the patient is deaf. So the initial history taking, clinical examination, investigation should be as similar. Whether the patient has undergone cochlear, of course, patient who is deaf and having sensory neural deficits will have a cochlear implant. But those patients who come to you, say a small baby or a small adult or maybe an adult patient who has deafness. So how to go about it? So I'm trying to combine both of it. And of course, I'll just at the end tell what precautions and what things to be done if the patient has undergone a cochlear implant. So when we get a patient, history taking is most important. Clinical examination, investigations, precautions, and anesthesia care. So this is the way I'll go. So while history taking, the age of the patient is extremely important. If it is a small baby or a pediatric patient, at what age the patient has undergone cochlear implant, or if it is an adult. Now we have done last Monday, we did a patient who was 80 years old and he wanted to have a cochlear implant, and we have done one. 80 year. I mean, the highest I did was 84 years old. So we have a long history of even adult and elderly patients who have undergone cochlear implants. Next question we'll ask the duration since the implant. When was the implant done? How long ago? And where the implant was done. So implant address, email, contact number, and the implant details. So if you have such details, you can easily, if you have a friend, like say Prajakta has done one implant, you can directly link up Prajakta, this patient is there, she can definitely give more information about the patient rather than, of course, you will examine the patient and take the history out, but directly you can get information regarding the patient. And of course, when was the last follow-up done with the center, because they have to come after, say, after 1 year of counseling and speech therapy and all. They usually, again, every yearly or 6 monthly, they come and follow up with the implant center to see the proper functioning of the electrodes and all those. So this follow-up information will tell you whether the implant is functioning properly or not. This is very, very important medically. So we'll go through it. So bilateral sensory neural deafness could be either congenital and acquired. We have already seen. So congenital, of course, genetic mutation, members of the family are deaf. So that is why I'm saying if you get a deaf patient, not undergone cochlear implant, so this is how you have to go. You have to go very thoroughly. Otherwise, a patient of 3 years baby is deaf, has come for a hernia surgery, and you will miss a lot of things. So you have to know all these things to follow up. Okay, what all things is the deafness in the congenital in the family? There are many members in the family who are deaf, or has a torch infections during pregnancy. Of course, Prajakta has explained all those toxoplasmosis and syphilis, varicella, Zika, rubella, cytomegalovirus, and herpes simplex virus. So torch, you have to do testing of ELSA. So that will tell you which group of torch infection has the patient. So the most common, which leads to bilateral sensory hearing deafness, is rubella and CME. Of course, then followed by toxoplasmosis and other herpes simplex virus. So this is very important. So even if the patient is deaf, so you have to find out all this. Okay. Then, of course, this congenital syndrome, which also has bilateral sensory neural deafness, already been discussed. Now, I have done all the symptoms, syndrome maybe we have done, except for Alport syndrome. I'm yet to see a patient with Alport syndrome coming for cochlear implantation. The rest all we have covered. So I'm not going to repeat this slide. So this is how my slides are moving fast. So you have to be careful about Jarvell and Lange syndrome, Linson syndrome, where if the patient is deaf and he gives history of syncope, always do an ECG and see whether there is a prolonged QT interval, because these are very dangerous. My article will give what drugs to use, what drugs not to use, how to prevent, what precautions to be taken, and if the patient goes into ventricular tachycardia, how to manage, and then post-op. Everything is given in that paper. So now we'll come to the acquired causes. So acquired causes of deafness, of course, is loud noise exposure, who are on the construction worker sites and all those guys. Aging is pressed by QSIS. As you age, the hearing decreases. Medical conditions, of course, Dr. Pradeep sir has mentioned: meningitis, measles, mumps, chickenpox, CMV, persistent otitis media, medical problems like diabetes, blood pressure, and cardiovascular disease. Trauma, head injury, and rupture to the eardrums like loud blast, especially our soldiers who hear those loud blasts and their loss of hearing. And of course, ototoxic drugs. Now, ototoxic drugs, we always keep on saying nephrotoxic drugs, nephrotoxic drugs. All the nephrotoxic drugs are also ototoxics. So why it was given, when was it given, and how long it was given? So what are the various ototoxic drugs? So it's a huge list of ototoxic drugs. So you may not remember. So best is to have a mnemonic. So mnemonic is calm ears. C is for cisplatinum and carboplatin. So these are the chemotherapy drugs. A is for aminoglycoside group of drugs. L is loop diuretics. M is malarial drugs like quinine. E is erythromycin. A is aspirin and salicylate group of drugs. And R, a rare reaction to vancomycin. So it is easy to remember. If you have a deaf patient who has an accord, he was hearing okay, but now he's not hearing. So you use the mnemonic and see which drugs which were given. Most commonly in India, we find either chemotherapy patients. We have done cochlear implant in patients who had undergone what do you say, recovery from cancer with chemotherapy and lost his her hearing. So we can find out that. And commonest is tuberculosis, aminoglycoside group of drugs, amikacin, gentamicin, given especially for tuberculosis 8 months, 9 months. So they usually go into nephrotoxicity or ototoxicity. Both can happen. So but not all ototoxic drugs can lead to bilateral sensorineural deafness. So if you see the aminoglycoside group of drugs and the chemotherapy group of drugs can lead to bilateral progressive permanent sensorineural deafness. The rest other group of drugs which can see is that loop diuretics, salicylates, quinines and all, they cause reversible bilateral sensorineural deafness. So patients can use after some time it can reverse. So till then, the patient can use various hearing aids. They need not undergo a cochlear implant because the basic requirement for cochlear implantation is bilateral profound sensorineural deafness. So now comes the clinical examination and examine, of course, all systems. We always do airways and all those. If you have a baby who is having a syndrome, whether it is having cochlear implant or deaf, go through entire group of things because we don't know why the patient is deaf. Especially in pediatric patient, it is usually congenital. So go through all those things. So whether it is a deaf patient or a cochlear implant patient. If the patient has a cochlear implant, see the exam or examine the implant site. So the various parts of which Dr. Pradeep sir has mentioned, I'm going to go briefly because I have to also mention. So examine which ear the cochlear implant is done, whether it is the right side or the left side. See the slide, whether there is any swelling, redness, discharge. So you know the site of whether the site is okay, whether there is an infection, whatever, and how the patient can communicate, hear, and cooperate, because this is extremely important if the patient is come for some other surgery. Then investigations, of course, the routine investigations we know for anesthesia and for some for cochlear implant, patients who have undergone a cochlear implant, if the patient has some congenital or acquired causes. So hematological, biochemical. If the patient has an acquired cause because of aminoglycosides, always look for the kidneys, do a complete renal function test. If it is an acquired, again, go through all the various X-ray, ECGs, and maybe sometimes 2D echo, because the rubella syndrome, usually they have a congenital heart disease. Most of them, always they have a congenital heart disease. So rule out, auscultate for murmurs, everything. X-ray chest is also important. You can see if there is a enlarged heart because of the shunts and all. ECG and echo, especially in congenital, of course, if it's the JLL syndrome, history of syncope, coming for surgery, always do ECG, calculate the QR interval, QT interval. That test is called by a formula called as Besset's formula. So always calculate if the QT interval is more than 500 milliseconds. Dr. Prajakta said, be careful. You must know which drugs to use, which drugs not to use, how to induce. Everything you should know, whether the patient has cochlear implant or patient is deaf. So you have to know this. And of course, the last point is implant details. Very important. Who has, where it was done, how long it was, of course, I have already mentioned. So all this they have to do. So in short, of course, Pradeep sir has already done this. So two parts, external part and the internal part. External part is the speech processor. There are two types. Now I'll just show you the photo and the transmitter coil. So speech processor, which can be hanged or kept inside the bush pocket here outside, or the transmitting coil, where the receiver of the internal, which is placed over the receiver of the internal component, is kept over the skin and kept in place with the help of a magnet. So, as Pradeep sir has already said, the speech processor, various microphones are there which captures the sound and filters the environmental noise and converts the sound waves into digital code. Usually it is a radio frequency wave. And the transmitting coil, which is sitting on the receiver of the internal component with the help of a magnet, sends the digital signals through wireless through the skin into the receiver of the internal components. So I'll just go through it. So this is how the external component looks. So this is the coil and this is the speech processor. So this was used in the long time ago. Of course, these are not available or not used, but they are the cheap ones. But it is difficult in pediatric patients to have this speech processor to be kept in the bush pocket because they run around and they can fall and they can damage. This is the commonly used, which is placed over the pinna, and this is the transmitting coil. And this is, of course, the internal part, which Pradeep sir has already explained. So this is the internal component. This is the receiver, which is the digital signal, which receives the digital signal and converts it into electrical signal, which is placed below the skin, which sir has already said. I'm not going to details, and the area of electrodes, which is placed inside the cochlea. So the receiver will receive the radio frequency waves, convert it into electrical signal, and then transmit it to the electrodes in the cochlea. This electrical impulse will be converted and sent to the brain, and you have the perception of sound. So this is how this sir has already mentioned. Fantastic video by sir. So this is the receiver, and these are the various parts which we have already said. So this is the internal part, this is the external part, processor, everything. Now, why I'm saying all this, because this will come in the next part of the talk. So in the pre-op preparations, NBM, as per the ISA guidelines, we know there's nothing much to be done. Informed written consent, because this is very, very important. Always take consent that there may be a chance, we can percentage, we don't know exact percentage, that there could be damage, malfunction, or even failure of the device. So the patient and the relative should know that patient is undergoing surgery because they have already spent so much of money, even if it is given government aid, but still it's a precious implant. So they have to know that there is a risk involved, whichever may be 0.01%, 0.05%, whatever. This has to be told. Okay, this can happen. Antibiotic prophylaxis is must because there's an implant inside your body. So 60 minutes prior to the surgery, better to have antibiotics. Now, what precautions to be taken before the start of surgery? Okay. So if the patient is cooperative, usually the adult patients, they are cooperative, and you need not remove the external component. So I showed you the processor and the transmitter coil can be with the patient, still you induce the patient because you can communicate and they can hear. And once after induction, remove that external component and hand it very safely to the relatives because this is also costly. If it is a pediatric patient and uncooperative patient, remove the external component and give it to the relatives. And usually we take a signature. Okay, we have handed over the external component to you. Otherwise, sometimes in that this thing, the receiver will fall down or it get lost in the confusion in the OT. Better to hand over the external component to the relatives. Then the head should be turned on the opposite side of the device. So if it is on the left side, you can turn the right, keep the head on the right side, or vice versa. Silicone ring paddings onto the head and soft cotton paddings. This is to prevent the implant getting hurt. Usually, intraoperative patient doesn't move and nobody hits the head during surgery. So usually better to keep it on the opposite side. Antiemetic prophylaxis is must. I will discuss. Sonali Prajakta has already said we use ondansetron and dexamethasone, but sometimes even after cochlear implant surgeries, the nausea and vomiting just continues, and I don't know what Prajakta does, and I'll tell you what we do, because even after giving ondansetron, repeat 2 hours, 4 hours, 6 hours, repeat dexamethasone, patient keeps on puking, nausea. So we'll discuss about that. And of course, extremely strict aseptic precautions, because there should be no infection even during the surgery and while giving you anesthesia drugs. So strict aseptic protocol has to be followed. So unipolar cautery, Pradeep sir has already mentioned, cannot be used. Unipolar cannot be used. Bipolar cautery can be used, but in short burst. But the use of bipolar cautery should be at least 3 to 5 centimeters away from the device. It has to be very much away from the device. And if you're having head and neck surgery or somewhere near the head surgery where the device is very close to your incision, then use of this is also quite dangerous. Safest is harmonic scalpel. That is, we know ultrasonic energy source is used where there is no electric current. So harmonic scalpels and scissors are very safe to be used. Now, a key point to remember, um, anesthesia care, regional anesthesia, neuroaxial anesthesia, general anesthesia can be safely given depending upon the type of surgery. Only thing is that you know what things to be done. External processor has to be kept away. Care for the implant, head on the opposite side, silicone padding, all those things. Standard intraoperative monitoring as per ISA guidelines, standard post-op analgesia and post-operative care. Sometimes, you know, for medical legal person, you have taken a consent, but better after the surgery, if the patient is okay, they can go to confirm the good working of the device to a qualified audiologist who will confirm that, okay, the surgery, before the surgery, the device was like this. After the surgery, the device is like this, because the device is quite costly. So that will give a complete reassurance and safety for you and the surgical team. Post-operative care standard, nothing much difficult. Now, some procedures, the after going cochlear implantation, patient cannot undergo. So it cannot undergo ionizing radiation therapy, cannot undergo electroconvulsive therapy, that is ECT, cannot undergo pain procedures. Now I do a lot of pain, so TENS and radiofrequency ablations, they cannot undergo after cochlear implant. Now MRI. Now MRI is one thing you have to be very, very careful, because patient is sent for MRI, and maybe most MRI centers, they know the protocol. This is the MR protocol for a patient who has undergone a cochlear implant. But if the patient has been received by some technician or some receptionist, they don't know anything, and they'll give you a direct call. Sir, patient aa gaya MRI ke liye, aap aa jao anesthesia ke liye, chota bachcha hai. Once you go there and then you see that there is something here in the ear and then some cochlear implant is there. So these are the dangerous situations where you can really land into big soup. So you have to be very careful. I'll just tell a few lines about it, but of course you can go in detail because there are multiple papers. Usually the patient who has undergone a cochlear implant has a booklet, do's and don'ts. So if they have a booklet, better refer it. If the patient is adequate, it is more easier to communicate. So few lines regarding MR protocol. So if you see how is MRI image generated, it is a strong magnetic field and the use of radio frequency wave. So the strong magnetic field will damage the internal component and radio frequency wave will hit the device. So now there are various types of implants which are available. This is called as MR rating. So it could be MR unsafe. That means it is not possible to undergo MRI, and then MR conditional. So there are some MR, the new devices which are come out, Advanced Bionics and Nucleus, those type of companies, they have come out with advanced implants which can undergo MRI, but then you have to go through it. So before starting, go through the details. So what are MR conditional implants? So usually the patient has an ID card which mentions the type of implant, where the surgery was, a surgical team, and the contact number of the implant company before. So the latest implant will mention static magnetic fields are compatible with 0.2, 1.5, or 3 Tesla. So that way you can undergo. Some implants in that you can go through the website of the implant company and they'll say that this implant may require surgical removal before MRI. That patient has to, will depend upon the condition that the implant has to be taken out before the MRI, or only the magnet has to be taken out. Some implant may require splints and bandaging kits to be applied over the magnet to prevent the magnet being changed from the position. So these splints and bandaging kits are not routinely used. They are provided by the implant company. And there is a way to tie that bandaging and kit and the splint over the receiving coil or the magnet, which is placed just below the skin. So go through the protocol. So what are the adverse events which can happen during an MRI? So there can be pain during and after the scan due to the heating. So the skin heats up because of the radio frequency wave, the whole device heats up. Skin swelling, breakdown of the implant magnet. Surgical repositioning, replace the implant magnet or replace the entire device. If the device, there's a device failure by mistake, if the correct protocols are not maintained, there can be a device failure also. Infection if there's going to try to remove the magnet and all that stuff. So As per the MR protocol, there has to be a standby surgical team, audiologist, and extra device kept separately. The same device, extra device separately. So if there's a malfunction, the patient, they can go for. So all these things has to be explained before an MRI is done. So this was an ultra short, which I tried to fit it in last 20 minutes. So you can go, you can read about it. It's given in Google. MR protocol in a patient who has undergone cochlear implant coming for MRI. So at the end, I'll just want to say this is the center where I do the cochlear implants. It's called as Big Ears, established in 2006 by Director and Head of Department, Dr. Neelam Vaid. Of course, Dr. Pradeep sir must be knowing her definitely. And co-consultants, Dr. Ajay Kothadia and Nikhil Gokhale. Chief of Anesthesia is me, Dr. Rajeshri Godbole, and this team of anesthesia. Of course, there's a lot of advanced hearing, auditory rehabilitation, speech therapy, genetic counseling, all those things we do besides white cochlear implants. So this is a slide which is commonly, of course, Dr. Pradeep sir also shared. Thank you for listening. And thank you again, ISA Thane, for giving me this opportunity. Now we should have a good discussion. Thank you.
Thank you, sir, for an excellent lecture. I think I'm looking at the chat box and we don't have many questions there. But I personally would like to ask you, that during these cochlear implant surgeries, arrhythmias are common, that Thane syndrome and even when you stimulate a implant, it can cause arrhythmias. And they say while defibrillating the patient, instead of a traditional axis pad position, anterior-posterior position is preferred. So why?
Come again. Sorry, Vijay.
So actually the arrhythmias are quite common. It seems like in cochlear implant surgeries, especially they have some Thane syndrome, and if we have to defibrillate this patient, so they say anterior posterior pad placement is preferred.
So usually we have this padding which is placed before the start of surgery. Especially with JLN syndrome, the external pacing is kept ready. So you don't have the patient to going on to ventricular arrhythmia and VTAC or Terrace's point test. So we apply the external padding before the surgery, anterior posterior.
Yeah.
And if the patient goes into arrhythmia, you can directly pace the patient. So that's one. And of course, we try to prevent all the drugs which cause prolonged QTC. So all the drugs, there's a huge list of drugs. If you just go through it, right from antibiotics to antiemetics to even reversal, you can't reverse the patient. Neostigmine is contraindicated. Glycopyrrolate atropine is contraindicated. So you have to reverse the patient as the patient wears out of the relaxant. So it takes a long time. You cannot use inhalation agents. Any inhalation agent, whether it is isoflurane, sevoflurane, desflurane, whichever. So if you have such a syndrome, always call your friend anesthetist and read about the entire group of drugs to be used, not to be used, what precautions to be taken. Of course, Samrat will tell more about defibrillation and all. But usually for such patients, we always take an external pacing with a wire attached. So if there is any VTAC, we can directly do DC shocks. Have to be very careful.
Yes, sir. Thank you, sir.
Sir, questions are more important. Sonali madam.
I think it's open to forum. You can directly ask question to sir.
Pradeep sir is there.
There is one question in the chat box, sir.
Yeah, tell me.
Whether you use any for TIVA, if you're giving, would you use any EEG or entropy or BIS?
No.
And one more question was, any antiarrhythmic drug that you would
usually
keep,
commonly is IV magnesium we commonly keep. Of course, depending upon the arrhythmias, we keep all the antiarrhythmic drugs. Entire array of antiarrhythmic, right from amiodarone, adenosine, entire it could be lignocaine, all the antiarrhythmic drugs. You have to keep it standby.
Great. It was nice talk, sir.
Thank you, Leah. Thank you.
Yatin, you want to?
Yeah.
Sir,
Before you Before we proceed to the next speaker, I guess I feel Dr. Uppal sir will leave. So I just want to express my heartful gratitude and huge thank you to our esteemed speaker, Dr. Pradeep Uppal sir, for explaining cochlear implant procedure in detail and in very simplified way for all of us to understand. And hats off to you, sir, for doing such a noble work and helping all those in need and those who can't afford with the help of TMC and other grants. And thank you, sir, for your research on Horoscope. Thank you so much for,
Thank you very
sir,
much.
for blessing us.
Thank you,
Yeah,
Sonali, and thank you, the whole team.
thank you.
Thank you,
Thank you,
sir.
sir.
I'll take a leave. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. Richa?
Yeah,
Hello, Dr. Richa?
yeah.
Richa,
Hi,
yeah.
hi, Atin. Yeah.
Hi,
Um,
Richa. You
good.
can,
Okay,
yeah.
now we'll proceed the thing. Good evening, everyone. Thank you, Thane Anesthesia Society, to give a chance and opportunity to as a moderator. With the rising elderly population and expanded indication for cardiac device anesthesiologists, frequently encountered patient with a pacemaker and implantable cardiac devices. This basically it's both as well as emergency as in a normal condition. So today we are having with us the dynamic Dr. Samrat Madnai. He is a DM cardiac anesthesiologist. He has done a fellowship also in cardiac critical care as well as echo and ECMO. The most important, he was the part of the cardiac team that performed the first successful adult heart transplantation in KLA Hospital, Belgaum. Requested to you, sir, kindly proceed with the session.
Thank you,
Pacemaker
ma'am.
and anesthesia.
Yeah, thank you, ma'am. Thank you. I'm humbled by that introduction. Let me share my screen first. So, is my screen visible right now?
Yeah, it is. Just
Okay,
starting.
just a second. Yeah. Yeah. So, good evening, everyone. Good evening, respected seniors, my colleagues, dear friends. And first of all, at the outset, let me thank ISA Thane and all the national dignitaries as well as the state dignitaries who are present right now for giving me an opportunity to present at this prestigious platform. So, without any further delays, I'm going to talk about pacemakers and how I deal with those patients, especially in the perioperative period. So, I'm going to talk about pacemakers and anesthesia. Myself, Dr. Samrat, and in coming some time, I am going to take you into the world of pacemakers. Disclosures, anything wise in the presentation, you should credit to the many experts who have preceded me. Anything foolish, please assume it as my error. These would be the objectives of my talk. I'll go in brief about the introduction and through the history. I'll tell you what are the different perioperative fatal tachyarrhythmias as well as bradyarrhythmias. I'll take you in short in the world of pacemaker, AICDs, CRTs, and things to do and not to do perioperatively. And finally, there is a take home message. So I always say, or I always wonder how they used to anesthetize the people in olden times. Maybe it was like this. I'm glad I'm not in that era, or this talk wouldn't be happening. Now look at this image. What do you see over here? Well, a man is getting scared by what we see as a monster. Is it actually a monster? Well, the fact is, it's absolutely not. It's a small problem, but we have created a monster out of it. So whether this world of arrhythmias and pacemakers and CRTs, whether is it really a monster that we should be dreaded about, or whether we are making the problem very big, let us see and let us try to demystify it in the coming slides. A word about history. So basically, Dr. Mark Lidwell, way back in 1926, he has made the first use of pacemaker, and that too that was in a neonate. Basically, he had developed his own device which was operated on a battery. And what initially in his experiments he found out that whenever electricity was applied to any muscle, it would develop a twitch. So when he was operating once, a baby, unfortunately a neonate, had a cardiac arrest, and in 1926 was the first time when he used this device on a neonate, and this was probably the first use of pacemaker worldwide. So if you look at the history, way back in 1940s, there were AC powered pacemakers which were tethered to extension cords, and they were huge like this. So patients who required pacemakers, the pacemaker device was so big. In 1950s, again, the battery powered these big devices, they transitioned to wearable devices, but still they were big. As the era progressed, in 1958, first fully implantable pacemaker was developed. In the current era, if you ask me about the recent era, we are in an era of implantable pacemaker, basic systems what we implant nearly in all the setups. And currently, in the past couple of years, few years, we are moving towards the leadless pacemaker. That is, you don't require external pacing lid for that. This entire device is inserted into the endocardium. What about the future? So in future, there is going to be batteryless devices which can harvest cardiac motion power and they can power themselves. So this is going to be the future, and all these devices are under experiments and under research purpose. Now, if you look at the ACC/AHA guidelines, 2014 guidelines, you will find that significant arrhythmias are a major cause of perioperative mortality and morbidity. So significant arrhythmias, definitely for us as anesthesiologists, as perioperative physicians, they play an important role. Now, when is a pacemaker indicated in any individual? So in short, there is an huge list for pacemaker indications, but just for the sake of simplicity and for the sake of talk, let me take you to few important things or few important indications. So the first important indication is sinoatrial nodal disease, which includes symptomatic sinus node dysfunction. It can be tachybrady syndrome or it can be chronotropic incompetence. In cases of second degree AV block, that is Mobitz type 2 block, we use or the pacemaker is indicated, and also in third degree heart blocks, that is complete AV blocks, pacemakers are indicated. A thing to note here is that in Mobitz type 1, that is the second degree AV block, that is Mobitz type 1 block, permanent pacemakers or pacing is not the first modality, that is.
Sir, voice is not audible. Dr. Samrat, voice is not audible. Someone will please check it out. Voice is not audible.
No audio.
Yeah. No, it's better. Now we can hear. No, Dr. Samrat, voice is not audible.
No, we are not able to hear anything.
Probably he also cannot hear us.
I'll just check with Ganesh.
Yeah, can you just call him, Yatin?
Yeah, I'll just call him. Yeah.
Yeah. Thank you.
Yeah. हॅलो गणेश आपले जे स्पीकर आहेत ना डॉक्टर सम्राट ही इज नॉट ऑडिबल.
No,
हॅलो
Dr. Samrat, you are not audible. We can't hear you. Can you hear us?
Yeah, am I audible right now?
Yes, sir.
Yes,
It's
sir.
better. Yep, sir.
Yeah. So did you hear me from the beginning or it was not audible at all?
No, it was 3-4 after 3-4 slides.
Indication. From indication you can start.
Yep, sir.
Okay.
Please.
Okay. So I hope the screen is visible right now and
Yep.
I am audible currently.
Yes, sir,
Yeah.
you are audible also.
Yeah. 1 second. So, so I think we went through the history of pacemakers.
Yes, we have gone
And
through. Yeah.
yeah, I'll just tell you about the different indications.
Yep.
So if you look at the 2014 AHA ACC guidelines, significant arrhythmias, they play a major role in the perioperative morbidity and mortality. Now, there are certain specific indications for pacemakers, and I'm not going to go through the detailed list of these pacemaker indications because it is a huge list. But to know about the important indications, you should know that sinoatrial nodal disease, which includes symptomatic sinus node dysfunction, tachybrady syndrome, and chronotropic incompetence, along with Mobitz type 2 block, that is secondary degree heart block, Mobitz type 2, and complete AV block. These are the absolute indications for a patient who has this kind of patterns, that is indications for pacemakers. Remember that first degree heart block and Mobitz type 1, that is second degree heart block, Mobitz type 1, do not become absolute indications for pacemaker. Now, what is a pacemaker? A cardiac pacemaker is an implantable electronic medical device that delivers timed electrical impulses to the myocardium to initiate or maintain an adequate heart rate and rhythm when heart's intrinsic condition system fails to do so. So the core functions include sensing the cardiac activity, pacing the atria or the ventricle or both, preventing symptomatic bradycardia and asystole, and maintaining AV synchrony. Now, if you go through the guidelines, it is important to note that there is a level class 1 C level of recommendation C in the AHA guidelines, which say that it is recommended that the hospital nominates a person who is responsible for programming of the implanted arrhythmia devices before and after the surgery. So this is an important point to note, that it is essential that we program the devices before and after the surgery, especially if the surgeries are elective surgeries. Now, before moving into the world of pacemakers, let me take you through, in brief, through perioperative tachyarrhythmias and bradyarrhythmias, which are near fatal. So first such tachyarrhythmia is ventricular tachycardia. We all know it, how it looks like. So this is how it looks like on the monitor. So basically the rate is very high, 100 to 200. The QRS and P wave do not have a fixed relationship and the rhythm is irregular. So this is how it looks like on the monitor. So this is all VTAC. The second perioperative tachyarrhythmia, which is fatal, is ventricular fibrillation. I'm sure all of you know this. This is how it looks like. So it can be either coarse ventricular fibrillation or fine ventricular fibrillation. And remember that it is always irregular and it is grossly disorganized. So this is how it looks like in real time. So this is a patient undergoing cardiac surgery, and this is ventricular fibrillation which is occurring. So always remember, either ventricular tachycardia, especially pulseless ventricular tachycardia, and ventricular fibrillation results in no effective cardiac output, and these are dreadful things wherein emergency resuscitation efforts should begin as early as possible. Coming to bradyarrhythmias, sinus bradycardia, we all know that the rate is usually less than 60, the rhythm is regular. The P to QRS relationship is 1:1, and this is how it looks like on the monitor. Remember, the patient does not need treatment for sinus bradycardia unless he is symptomatic. But also, you have to remember that in presence of a slow heart rate, patients with a diseased heart may be unable to maintain adequate cardiac output. Coming to first degree heart block, this is how a first degree heart block looks like in the monitor. So basically here the PR interval is more than 0.2 seconds. This is how the heart beats in normal sinus rhythm. This is how it beats in first degree heart block or in AV block. Second degree heart block is divided into Mobitz type 1 and 2. So on screen, this is Mobitz type 1 block, wherein you will see progressive prolongation of the PR interval and until suddenly a QRS complex is dropped. So here if you see, this is progressive prolongation and then suddenly a QRS complex is dropped. So this is second degree heart block, which is Mobitz type 1. Coming to Mobitz type 2 block, remember that Mobitz type 2 block reflects intermittent and sudden loss of conduction between atria and ventricle, and there is no progressive prolongation of the PR interval, but suddenly a QRS complex will be dropped. So if you see such a picture on the monitor, remember you are dealing with Mobitz type 2 block, which is second degree heart block, which is more dreadful than the first degree heart block, and this absolutely needs treatment. So whenever you are dealing with these arrhythmias, always remember you should keep your perspectives open. So in this first image, if you see here, what do you see here? The children are sitting on the wall, but how are the chairs present on the wall? So if you look closely and if you change your perspective, you will understand that this is the reality. So similarly, while dealing with patients with arrhythmias and pacemakers, you should keep your perspectives open. Coming to third degree heart block, remember it represents a complete absence of conduction between the atria and the ventricles, and there is no relation between the P wave or the QRS complexes. So there is absolutely no relationship. This is how a third degree heart block looks like on a monitor. A word about asystole, again, sometimes in bradyarrhythmias or in patients who have sudden cardiac arrest, you will be dealing with asystole. But before this is diagnosed, always remember your pacing, this ECG leads, electrodes are attached to the patient. And this again is an emergency situation, again, wherein emergency resuscitation efforts should begin. Now, just to sum this up in a more enthusiastic way, I have compiled. This is one of a compilation, and this basically I have got it from the internet. This is not my own compilation, but let us assume that this ECG is the life, and we'll consider P wave as the wife and QRS as the husband. So in normal sinus rhythm, remember that this is the P wave and this is the QRS complex. So basically the husband, that is QRS, always comes after the wife P, and it is regular and they are always happy. In first degree heart block, the husband QRS, he comes after the wife P, but he comes slightly late at the same time every night. So this is basically first degree heart block, slightly troublesome. Second degree heart block type 1, that is Mobitz type 1, the husband QRS, this is QRS, he comes home later after the wife P, and the duration of his stay progressively increases until one night he doesn't come home again, and the same routine continues. This is more dreadful. In Mobitz type 2, sometimes the husband QRS comes home, sometimes he doesn't, and the wife P is waiting, but when he comes home, it is always the same time, and this is absolutely serious and requires more counseling, that is pacing. In third degree heart block, the wife P is no longer waiting at home. She and her husband QRS are now on separate schedules. They have no relationships and no longer talking. And absolutely, this requires counseling and pacing. So after this fun, part, let us see what actually pacemakers are. So the cardiac electrophysiology may be complex, but remember, perioperative care of the patients with cardiac implantable electronic devices should not be complex at all, especially for perioperative physicians and anesthesiologists. How is a pacemaker and how does a pacemaker look like and how is it implanted? So this is a short animation showing how a pacemaker is implanted. So all of us know that this pacemaker is implanted by the transvenous route. This is a permanent pacemaker implantation which is being done. The most preferred route is this subclavian on the left side. So usually they take a puncture first, then the guide wire is passed. After this, the introducer sheath is introduced. Then goes your pacing leads or pacemaker leads. Once they enter the right atrium, they traverse the tricuspid wall and into the right ventricle, and then they are screwed in so that they stay in place. Now, basically, this pacemaker, it is placed under a small pocket. This is usually the infraclavicular region, and this is the pectoral region, and a pectoral pocket is prepared. And this is how a pacemaker, permanent pacemaker, looks like. So this is a pulse generator. These are the pacing lids. These pacing systems can be either single lid or dual lids. I'll show you in coming slides. On the X-ray, it looks like this. So this is a ventricular lead, which you can see in the right ventricle, and this is an atrial lead, which is in the right atrium, and this is the impulse generator. So on the X-ray, if you find an X-ray something like this, you are dealing with a pacemaker. What about this automated implantable cardioverter and defibrillators? So basically, these are advanced versions, kind of pacemakers, but advanced versions. You can say they are like mini computers, wherein they diagnose the ECG, see whether there are trachyarrhythmias or bradyarrhythmias, and accordingly, they either give shocks, that is cardioid, or defibrillate the patients accordingly. So this is how it happens actually. So suppose this patient is having a fast ventricular tachycardia, this will be sensed by this AICD, and then there are internal chips in it which sense this and diagnose this, and then the shock is delivered to the patient so that the sinus rhythm or whatever is restored. So this is how it works. AICD on an X-ray will look like this. So you have an atrial lid and a ventricular lid. But point to note here is that the atrial lid and the ventricular lid, slightly the coating will be slightly thick because you need some part of it or coils of it to defibrillate the patient. So this is how it looks like on an X-ray. Coming to CRT, that is cardiac resynchronization therapy. Basically, these are the devices which are used whenever you are dealing in patients with low ejection fractions, and especially when resynchronization therapy in cardiac patients is indicated. Basically, what happens here is there is one lid which goes into the right ventricle. You have one lid in the right atrium, and there is another lid which traverses via the coronary sinus, and it tries to pace the left ventricle also. So basically, the dysynchrony between the right ventricle and the left ventricle is overcome by this therapy. So this is CRT. A CRT will look like this on an X-ray. So you can see the atrial lid over here. This is the ventricular lid, and this is the coronary sinus lid over here. So if you come across an X-ray which shows you 3 lids, basically you are dealing with a CRT device. In this current era, we are moving towards leadless pacemakers also. So what are these? So and how they are inserted? A short animation for the same. So basically, from the femoral root, the guide wire is passed, and then the introducer sheath is passed. So there are different companies and systems which are available for this leadless pacemaker implantation, and these devices are available. So once this introducer sheath is passed, the system is in place. So under fluoroscopy guidance, the right ventricle, the apex or the distal part of the interventricular septum in the right ventricle is seen. And then with the help of this deployer device, the lidless pacemaker is implanted. So I'm not going to go into the structural details of how it is done. This is just to show you how a leadless pacing device currently is inserted. Again, this is a beautiful video intracardiac showing how this actually goes. So this is not in a real-time patient. This is in a model, 3D model that they are showing. So the advantage of this is the battery, it does not have any connection. It will get attached on the endocardial surface, and there will be no external impulse generator which is required for this leadless pacemaker. So we are currently in this era. At the end, there is tether removal, and then this system is withdrawn, and the lidless pacemaker, it stays in situ. How does it look like on an X-ray? Well, the X-ray picture looks somewhat like this. So if you come across such a picture, remember there is a lidless pacemaker in the patient. This is important, especially if the patient is not giving any history, and if you come across an X-ray like this, it is always important to interrogate or go into further details of these patients. Now remember, this is one part. This was what we were talking about, the permanent pacemakers, but many a times we come across also with patients who have temporary pacing devices. So basically these temporary pacing devices can be of 2 types. They can be single chamber or dual chamber. So in the first image over here, what I'm trying to show you, this is a single chamber pacing device, and this is a temporary pacing device. So basically what it does, it takes the part, or it plays the role of the impulse generator in like what we have seen in the permanent pacemakers. So basically you can set the rate on this, you can set the amplitude, that is the output on this, and then again you can set the sensitivity, that is at what level you want to capture the signals from the endocardium. This all things can be set on this pacemaker. So basically this is a single chamber. Now there are also double chamber or dual chamber pacemakers, and which are especially required for AV sequential pacing, especially in cardiac surgeries in some critical patients. And this is how it looks like. So basically, you will have an input for the atrial lead, you will have an input for the ventricular lead, and you can time and synchronize this atrioventricular pacing on these different parameters. So basically, if you see here, there is only in this single chamber pacemaker, there is only one end. Only at one end you can connect the electrode, while in dual chamber pacemakers there are two ends wherein the electrodes of the atria and the ventricle can be inserted. Now on this pacemakers, you can set the rate, as I told you earlier, you can set the amplitude and the sensitivity. There are also different modes on this pacing systems. And what are these different modes? In brief, I'm going to tell you. So let us dive into the world of this pacing systems, or the different modes of this pacing system in short. So basically, the North American Society for Pacing and Electrophysiology, or the British Pacing and Electrophysiology, this group, that is the NASP or BPEG group. So they devised the generic pacemaker identification code. And basically, there are 5 letters for naming this pacing systems. So the first letter always denotes what the chambers are paced. The second letter denotes what the chamber are sensed. The third letter denotes what is the mode of response. The fourth letter tells us about the programmability and the rate modulation. And the fifth letter tells us about the anti-tachyarrhythmia functions. So this O means none, A means atria, V means ventricle, and D means dual, that is atria and ventricle. So for example, suppose a pacemaker nomenclature is VVI. So basically what is happening here, this pacemaker is ventricle placed, it is ventricle sensed. And what does this I mean? It means inhibition. So basically ventricle pacing will be inhibited whenever activity is sensed. So if your pacemaker is on this mode, basically what the pacemaker will do, it will pace the ventricle, it will sense the ventricle, and only if required, it is going to generate the impulses beyond whatever levels you have kept. And only after that, the impulse will be generated and the patient will be paced. Let us take another example, that is this is VOO, that is ventricular paced, ventricular not sensed, and no inhibitory response to pacing when activity is sensed. So basically what will happen in this patient is that ventricle will be paced, it will be sensed, but is irrespective of what is happening, irrespective, this ventricle won't be sensed, and irrespective of whatever is happening in the ventricle, the pacemaker is going to give impulses and it is going to pace the patient. So based on this nomenclature, you can come across the different nomenclatures like DDD or DDI, or nomenclatures I have shown you like this. This nomenclature basically means what are the chambers pace, sense, and the mode of response. Also remember, there is another type of pacing which is epicardial pacing. So this is one of our patient wherein we have paced, or he was giving trouble to come off bypass, so we had to do an AV sequential pacing. So if you see here, this is the atria, this is the ventricle. This is a video which has been rotated, sorry for that, but there are pacing wires on the atria and ventricle, and we have connected this to the dual chamber pacemaker, that is for AV sequential pacing, and this is how it looks like on the monitor. So we were having trouble in this patient while coming off bypass, and once we did an AV sequential pacing, the hemodynamics were stable and we were able to come off bypass. Now, whenever you are dealing with these patients of patients with either pacemakers or the CRT devices or AICDs, remember you should be able to diagnose what is happening with the patient based on the ECG. So even if you don't have the details of the device, if you see spikes just before the P waves, that means usually that the pacing is usually for the atria. If you see it before the QRS complexes, then that means that the pacemaker is for the ventricles. And in cases of AV sequential pacing, you will be seeing spikes before P waves and also before QRS complex. So this ECG perioperatively can give you insights into what actually we are dealing with or what type of pacemaker the patient is having. Now, always remember, whenever you are dealing with patients of arrhythmias or pacemakers, you should know what you are looking for, or else you will be landing up into situations like this. This man over here, he is trying to, he doesn't know, and actually they'll land up into a very dreadful situation if he continues like this. So whenever you are dealing with patients with arrhythmias, remember you should arm yourself with knowledge, or else you can land up in a situation like this. Now, just to move on further, let me take you to a case scenario. So we have a 63-year-old woman who is scheduled for an open cholecystectomy. She has underwent a dual chamber permanent pacemaker implantation 10 years ago for 6 sinus syndrome and intermittent heart block. Over time, she has developed systolic heart failure from greater amounts of ventricular pacing that resulted in an upgrade to CRT device 9 months ago. So basically, we are dealing with a patient who has a CRT device which has been in place 9 months ago, and before that, she had an permanent pacemaker 10 years ago. Now the hemodynamics are fine. Blood pressure is 110 by 68, and the heartbeats are around 60 beats per minute. And an ECG is obtained on admission, which shows that the patient is atrioventricular pace. So keeping this background in mind, let us see or come across few scenarios what can happen intraoperatively. So why did this in the first place? Why did the patient progress to heart failure gradually? So whenever you are dealing with patients of pacemakers, you should remember that whenever only the right ventricular is whenever the right ventricle is paced, this results in the activation only of the right ventricular septum first, followed by passive activation of the left ventricle towards the free wall. And this forms a contraction of the heart, that is the right ventricle and left ventricle, which is dysynchronous. And studies have shown that over years, this potentially worsens the congestive heart failure symptoms and the left ventricular ejection fraction reduces. So that is why in our patient earlier, this lady initially she had a PPM 10 years ago, and this was basically the lid must have been inserted into the right ventricle. And over the years, because of this dyssynchrony, she developed or further progressed into heart failure. And currently, she had to undergo a CRT device. So this is one important reason, that is you should remember that some subset of patients who have permanent pacemakers, they can have ejection fractions towards lower side, and that can be due to the dyssynchrony between the right and the left ventricle. Now, before subjecting this patient for any surgery, you have to subject the patient for a few preoperative checks. What are those different checks which are important? So the first and foremost is you should be able to identify the device, which is most important. Whether it is a pacemaker, an ICD that is AICD, or whether it is a CRT, well, definitely the X-ray, if you are a very novice, X-ray can give you into insights of what is happening. I've already explained you how an pacemaker looks like or how an CRT device looks like on an X-ray. You should also know or look into the notes of what types of pacemaker it was implanted, whether it was a single chamber, dual chamber, or the types. You should look at the manufacturer model and number, implant date, and the last interrogation date, and indication for implantation. If the patient is having a pacemaker or an ICD, you should always look for an ID card wherein you will get all the details regarding the same. Now, always remember, if you come across patients like this, it is always important to interrogate this patient. And one of the important steps of interrogation is also calling a proper trained personnel who can give you or interrogate this device, that is usually from the cardiology side, and who can tell you into the details of this device. The second question that you need to know or you need to understand is that whether the patient is pacemaker dependent. So whether the patient earlier had an history of complete heart block, whether the baseline heart rate was less than 40, if there are pacing spikes before every QRS on the ECG, and if you are unsure about this, remember to take help of your technician or the cardiology people who can interrogate this device. Always remember, pacemaker dependent patients are always at high risk in the perioperative period. The third and important thing that you should do further is you should know about the current status of the device that you are interrogating with or you are dealing with. So basically, you need to know what is the battery status, whether elective replacement indication is there. You should know about the capture and sensing thresholds, what are the different modes that the patient currently is on, and what is the rower rate limit, and whether if the patient is on ICD, whether tachytherapy is on or off. And ideally, this interrogation has to be done within the last 6 months. Now, this is true for patients who are posted for elective surgeries. In emergency surgeries, you can always skip this part. Now, always remember that you should know what you are looking for. In this first image over here, President Bush is trying to look at something. But if you look closely, his binocular caps are off. So basically, whenever you are dealing with such patients, remember, you should deal it with different perspectives and don't do it like what President Bush was doing in the previous image. The fourth important thing that you need to know is the type and site of surgery. And why this is important is because electromagnetic interference, that is the EMI risk in the intraoperative period, can interfere with the pacemaker function and you can make you land up into trouble. So what are these electromagnetic interferences which can cause risks in the intraoperative period? Basically, these are monopolar cauteries. If the patient is subjected for lithotripsy, if radiofrequency ablations are done, or if an MRI is planned, then there is an increased risk of this electromagnetic interference. Also, always remember that any surgery above the umbilicus, there is always an higher EMI risk. The fifth important part that you need to know or you need to understand is you have to decide on the device management plan. So remember, if the patient is pacemaker dependent and EMI is expected, always remember to program the pacemaker to asynchronous mode. If technician is not available or if you are in state of emergency, remember that you can always apply a magnet over the device which will turn it to asynchronous mode. So whenever you are applying a magnet to a pacemaker, automatically most of the devices will go back to asynchronous mode. That is, this EMI will cause interference with the pacemaker function. That is, the pacemaker is going to generate impulses irrespective of what is going to sense. But with the help of AICDs, always remember when you apply a magnet, it only inhibits the anti-tachycardia therapy. That is, only the anti-tachycardia part function algorithm of the device is going to get deactivated, but the pacing function is usually going to be unchanged. And patients who are on ICDs or CRTs, remember external defibrillators are always mandatory in the perioperative period or intraoperative period. So take home message over here is magnet or ICDs will turn off shocks. That is, they will turn off the deactivate the anti-tachycardia therapy, but they won't change the pacing mode. And that is why external defibrillators, especially the transcutaneous spacers, are very essential, or facility for transvenous pacing devices are also very essential in this kind of subsets. The next important thing that you need to do is get an ECG, baseline ECG, get a chest X-ray and the cardiac status of the patient. It is always advisable if it is an elective surgery to get an echo done. And remember, for backup and safety in the OT, especially for planning any surgery, external defibrillators plus pacing pads have to be there. All your emergency drugs like atropine, isoprenalin, epinephrine have to be there. And then continuous ECG monitoring, pulse oximetry should be done. And in patients who are at high risk or high risk subset of patients, make sure you get an invasive arterial monitoring line. Now, I had one such experience. This was with cardiac surgery. So basically, this was one of my patient who was in whom I was doing echocardiography. He basically was posted for aortic stenosis, and my resident had done the PAC, and it was a very busy day. This was the first image that I got. So basically, this is a plaques view. You can see here, this is the mitral wall, this is the aortic wall, left ventricle and right ventricle. So everything looks okay over here, except that the patient has aortic stenosis. The aortic wall is not opening nicely. Now, as I was going in the further part of this examination, what I found was this is apical four-chamber view, slightly focused towards the right ventricle. So basically, this is a focused RARV view. What I found here was there was an echogenic structure in the right ventricle. So basically, this is a pacing lid. The patient had underwent a permanent pacemaker implantation 7-8 years back. And unfortunately, my resident had forgotten to take the history. Even the patient had denied or told any such history. And this was caught up on echocardiography. So this is a 3D image of the same. This is a pacemaker lid. This is the right ventricle. And this is the pacemaker lid, what you are seeing in the same patient. So echocardiography, definitely it plays an important role in these patients, especially for knowing the different functions of cardiac chambers like left ventricular function, right ventricular function, and also for looking at the pacemaker leads. Now, once you are done with the preoperative part, there are some intraoperative checks you should not never forget before going further. So always remember, intraoperatively before induction, continuous ECG monitoring is essential. Pulse oximetry is essential. Invasive BP, if patient is pacemaker dependent, you have to do. And remember, ECG filter has to be set to diagnostic mode to visualize the pacing spike. If you're going to set it to monitoring mode, pacing spikes won't be available. In patients with ICDs or CRTs, always remember attach external pacing and defibrillator pads, and there are different positions for this. For EMI precautions or for EMI interference precautions, remember bipolar cautery is always preferred over a monopolar cautery. And unfortunately, if you are using monopolar cauteries, the cautery burst should be small, usually less than 1 second with lowest effective energy, and they should be at more intervals of more than 10 seconds. So keep the cautery burst less than 1 second, and the duration between these bursts have to be more than 10 seconds and with the lowest effective energy. And always remember, you have to place the cautery pad away from the pulse generator or the impulse generator. And this usually has to be at least 15 centimeters away from the impulse generator. And remember to avoid current path across the device lids whenever, especially when you are trying to defibrillate the patient. And you have to avoid proximity of the cautery cables near the device. Device management during surgery. Remember, if the patient is pacemaker dependent, again, turn it to asynchronous mode. If it is that is the DO or VO mode. If this is possible in elective surgery, get a technician, get it done on the asynchronous mode. If emergency surgery, just apply a magnet and it will get converted to asynchronous mode, and keep a watch on the ECG. In case of ICDs, remember, applying a magnet is just going to turn off the anti-tachycardia function, and external defibrillator must always be connected to the patient, and pacing mode is never changed when you apply a magnet in patients of ICDs. Anesthetic technique considerations. Remember, we have to avoid profound bradycardia, hypotension, and hypoxia. You have to titrate the agents that depress the rate or the rate and the conduction. So I'm not going to go into the drug details of all this because it is going to be an exhaustive talk if I go into it. And remember to maintain the electrolyte and the acid-base balance, and you have to avoid the excess vagal stimulation. So you have to remember that any technique, be it regional or general anesthetic technique, the goals are this: to avoid bradycardia, hypotension, and hypoxia. And regional anesthesia is usually safe in these patients. But in case of neuraxial blockades, remember, once you give the neuraxial blocks, suppose spinal, there will be peripheral pooling in these patients, venous pooling in these patients. And sometimes because of the decreased preload, the pacing lead, the contact of this pacing lead with the cardiac chambers can be troublesome, or it can give to some interferences. So you have to make sure that the patient is adequately preloaded in such situation. Now, always remember that in long QT syndromes, that is, avoid QT prolonging drugs, especially methadone, haloperidol, ondansetron, or high volatile doses of anesthetic agents. Suppose if you land up into a situation where there is an bradycardia or asystole, always remember to stop the electromagnetic interference, that is stopping the cautery, apply magnet, try to do external pacing, use atropine, isoprenaline, epinephrine as indicated. But in my experience, they are very rarely useful because they usually don't, revert back or increase the rate to a great extent. But definitely, if nothing is available, you can use this. And in cases of ICDs, remember to apply magnet and treat the arrhythmias effectively. Now, remember that in pacemaker dependent patients, tachycardia will not reflect hypovolemia because in these patients, these are pacemaker dependent patients. And suppose if this patient land up into tachycardia, it is usually because they are dependent on the pacemakers, and it will never ever reflect hypovolemia. And in such patients, meticulous volume management is necessary. The positioning and equipment, remember to avoid pressure over the generator sides, keep the magnets secured, and remember it is always better to have the technician besides or nearby who can change the modes of this pacemaker, especially in the perioperative period. Regarding MRI radiation and extracorporeal shockwave lithotripsy, remember in MRI no device is MRI safe. Even many companies say that these are safe devices, but there is to some extent there is some amount of hazard which is always there, and there is always a risk of lead hitting, tissue injury, and pacing changes. In radiation therapy also, remember there is always a risk of oversensing or reset or failure. And remember that you have to relocate these devices if it is interfering with your treatment field, especially patients who are dealing with oncosurgeries. You have to remember this. And in this shockwave lithotripsy, remember modern devices are safe, but if the patient is pacing dependent, before this shockwave lithotripsy, always change the pacing mode to asynchronous mode, that is VO or DO. Now look at this image over here. What do you think over here? What's happening over here? So this is an arrhythmia which is occurring, right? So is it actually an arrhythmia which is occurring? So absolutely no. This is electromagnetic interference which is occurring because of the cautery. And how do I say so? Because I'm correlating this with my pulse oximetry and arterial trace. So if you look here, even if you are looking at the arrhythmias over here, the arterial traces are quite good. Even if you don't have an arterial line, even the pulse oximetry traces are quite good. So you should always correlate this EMI interferences with the pulse, that is either with the pulse oximetry or your pulse on hand. And if you have an invasive line in place, better, it is more better. So suppose in this patient, the case that I discussed earlier, if intraoperatively the patient's heart rate keeps on increasing intraoperatively, like we are going for an open lap cholecystectomy in the patient that we discussed earlier, and the heart rate of this patient is gradually increasing intraoperatively. So what can be the reason? So remember, all modern pacemakers, CRT devices have an rate response adaptive pacing, and I have shown you in the nomenclature. This is denoted in the fourth column. And remember that this rate responsive adaptive pacing will increase the heart rate on the physiological condition of the patient. So surgery, general anesthesia, it is always a stressful condition to the body, and accordingly the pacemaker tries to reset it, and sometimes we can misunderstand that for inadequate anesthesia, and in such situations there is no need to increase the depth of anesthesia. It's always good to have a BIS monitor, but if you don't have this, always remember you have to keep in mind this point also. Remember, transcutaneous pacing can be done in these patients in cases of emergencies, especially in patients with AICDs and CRTs. And this is how a transcutaneous pacer can be set up. The application of the pads should always be away from the the impulse generators. So usually it is the anterior posterior part which we apply, or in some cases you can apply it over on this right sternum, and one towards at least 10 to 15 centimeters away from this impulse generators. Now, there are some newer technologies which are coming up, and one such technology is implantable hemodynamic monitoring, especially in heart failure patients. So what is happening is some lidless devices are being implanted into the pulmonary arteries, and they tell us about what's actually going on with the hemodynamics of the patient. So in near future, definitely we are going to come across these patients. The advantages of these devices are they help in the improved outcome in the perioperative period. They decrease the wall stress, they decrease the heart rate, and they decrease the rate of arrhythmias, they increase the renal function. And this is how it looks like on an X-ray. Still not widely available in our subcontinent or our country, but yes, they are coming up in a big way. So always remember, you should keep your head cool, you should have a strategy, and even in cases of emergencies, you have to always be cool for a good outcome, like the way we did in the last World Cup. So my take-home message is, remember, pacemaker dependency is functional. You have to identify the device and mode before anesthesia. The main intraoperative risk is monopolar cautery. You have to shift it to bipolar cautery, and I have already told you how long should the cautery burst be. Always remember that grounding pad away from the pulse generator is to be kept in mind. Keep a magnet handy, especially for asynchronous pacing, especially in cases of emergencies. Remember, pacemaker does not protect from hypotension, and reprogramming is always indicated before elective surgeries. External pacing defib pad should always be there or should always be available. You should have to avoid hypoxia, acidosis, hypothermia, and hypotension, and your basic H5H and 4Ts. And remember, post-op interrogation and restore settings of these devices have always to be done after the surgery is over or after the patient is shifted back into the ICU or whenever he is going to be get discharged. Do not keep the patient on the asynchronous mode, and you have to make sure that post-op interrogation has to be done. Remember the golden rule, pacemaker treats bradycardia and not poor anesthesia. These are a few of my references. Thank you.
Well done, Dr. Samrat. It's so amazing. It's just a feast for us. Every bit of aspects you cleared it very well, very nicely. Really, it's really impressed with such a feast for us, actually. Thank you so much.
Thank you. Thank you, ma'am. Thank you.
So the forum is open for the questions. So we'll just
I have a question for Dr. Samrat.
Yes.
For MRI in MRI compatible machines, if the patient
Right.
we want to do the MRI, do you suggest we should set the pacemaker to asynchronous mode?
Sir, now most of the devices, especially all the systems what we have, especially the Medtronic or the Abbott devices that we have, they recommend that these are pacemaker, these are MRI compatible. There is always a risk, as I already told you, that the lid rupture and all this very small risk is always there. it's not absolutely always essential to set the patient on asynchronous mode. But as I told you earlier, if the patient is with heart failure, and especially if the patient is on pacing dependency, and your MRI machine is of the older generation, then definitely it's always advisable to reprogram these devices. And if this is not possible, at least be prepared for the emergencies in the MRI SUTI, because the main thing here is you should not be caught, unattentive or unprepared, and you should have all your strategies in mind when you are dealing with such patients. But yes, with the newer devices, they are more MRI compatible, and most of the times they do not require your reprogramming pre-procedure.
Do you suggest that we should have temporary pacemakers also for?
Absolutely. So it's always essential to have a temporary pacemakers handy, because you never know what situation you can land up into. The only problem here is, suppose if you have landed up in the intraoperative period, basically I'm talking about, if you have a high EMI interference and unfortunately your permanent pacemaker or AICD has failed, even with this high electromagnetic interference, if you are going to do and temporary pacing, even that is going to cause a lot of different disturbance in this EMI interference is going to cause a lot of disturbance even with the temporary pacemaker. So you have to keep that in mind. So as I said earlier, the best strategy here is again to have a magnet, and stay, you should be thorough with your perioperative protocols and your perioperative algorithms for management.
Okay, thank you.
Sir, does magnet response differs between pacemaker and ICDs?
Yes, I told you before that. I mean, I have included in my talk. So absolutely yes. If the patient is just on permanent pacemaker, if you are going to apply a magnet, what the magnet is going to do, it is just going to convert that mode to asynchronous mode. So now basically what is asynchronous mode? Irrespective of this electrical interference which is occurring, the pacemaker is going to generate impulse at whatever rate the company has set. So mostly these devices are set at a rate of somewhere around 80 to 90. So if you apply a magnet, irrespective of what is happening in the heart, the pulse or the pacemaker is going to generate that impulse. That is, it is going to convert the pacemaker into asynchronous mode. Now, in cases of these ICDs or CRT devices, what happens is once you place the magnet, only the anti-tachycardia function, that is only the computing part of that anti-tachycardia function, that is going to get disabled. That means the machine, whenever there will be electrical interference, if the machine or your ICD device, if it is trying to take it as an episode of VTAC, then only that part is going to get abolished, not the pacing part. So the pacing part, what you have set in these devices, is going to get continued. Suppose you have kept the pacing part on this thing on synchronous mode, then the machine is not going to understand that basically this is electromagnetic interference. Only the anti-tachycardia algorithm which is there, it is going to get inhibited. So even if you keep a magnet in such patients, remember, and if there is a lot of electrical interference, then sometimes there will be sensing problems and pacemaker won't work properly. In such situations, you have to immediately tell to stop the electromagnetic interference. Suppose if the surgeon is using a cautery, ask him to stop that cautery. Or if there are any devices which are causing electromagnetic interferences nearby, you have to, stop or these devices. And then what you can do is you can always connect an external defibrillator or a transcutaneous pacing in such patients. And if possible, as earlier said, again, if transvenous pacing is available temporary, you can again insert such a device in this emergency situation. So that is the basic difference between an magnet application over ppm and an AICD.
Okay, thank you, sir. Just I think we can have a look on the chat box.
Yeah. Yeah, so someone is asking me what are the precautions to be taken during central venous cannulations. So very nice question. So during central venous cannulations, definitely there is always a risk that you can interfere with this sensing capabilities, especially when your guide wires are catheters are entering into from the SVC into the RA, they can cause some sensing problem. So in unstable patients, especially patients or in novice people who are trying to insert central lines, if possible, it is always indicated you convert the pacing to asynchronous mode and then do your procedure. But in cases of emergencies, you can just proceed ahead and you just can keep a watch on the vitals. But if possible, yes, it is always preferable to put it to asynchronous mode and then proceed ahead.
Yes. Any
Yes,
questions,
so
please?
yeah, one more question that I'm seeing is, does AICD resume its function immediately after removing the magnet? So yes, so this is a temporary phenomenon. Whenever a magnet is applied, for that time being, the machine is programmed for that sake. Once you remove the magnet, usually it resumes back to its original state. In some previous generation devices, the thing was, whenever you used to apply magnet, it used to get converted to asynchronous mode and then used to require a technician or a specialist to convert it back to your asynchronous mode. This was mostly in the previous generation devices, but in recent devices mostly it switches back to the normal mode or the previous mode that you have set in.
One more question is coming from the ophthalmic surgeries.
Yeah,
What precaution is to be taken for the eye surgery, especially retina, because they can't use a bipolar cautery that time?
Yeah, so basically, as I said earlier, with the help of monopolar cauteries, try to avoid this burst, whatever they are doing. Try to keep the energy as low as possible.
5 seconds.
Try to keep this burst as less as possible, less than 1 second if possible. And the gaps between this cautery usage or this burst what they are giving should be somewhere more than 10 seconds. So that would be the ideal way to go about it.
One is precautions during use of the PNS.
During PNS, nothing. I could not find anything per se in the literature, or I've never encountered any problem in my clinical practice, especially with the use of PNS and pacemakers. And usually, as I said earlier, you should just be watchful in the perioperative period. Nothing more is required in this type of this thing.
Any questions?
One more question is regarding the battery life. I can read over here. So battery life usually with the newer system, it is around 10 to 15 years. With the lidless pacemakers, if you ask me, it comes somewhere around, according to my knowledge, around 5 to 8 years or something like that.
Okay. Thank you so much, Dr. Samrat. The
Thank
screen
you.
is over to the Yathin and Dr. Sonali. Please take over.
Yeah, Yatin, you want to
Yeah,
do? Yeah.
Respected speakers, moderators, seniors, and dear colleagues, as we conclude this power-packed academic evening on behalf of ISA Thane, I rise to deliver the most awaited talk of the evening. Vote of thanks. Just kidding. I promise to keep it shorter than a short-acting anesthetic agent. My heartfelt appreciation and a huge thank you to our esteemed speakers, Dr. Pradeep Uppal sir, Dr. Prajakta More, Dr. Joy Shankar Jana, and Dr. Samrat Madnaik for making complex devices like cochlear implants and pacemakers sound far less intimidating than they usually do in the OT. And thank you for enriching us with all the knowledge and in a much a simplified way. You explained everything, and that I'm sure will help every delegate and all the people who have participated in their everyday practice. My heartfelt appreciation to all the SAMS office bearers who graced us with their presence. My sincere appreciation to our moderators, organizing scientific committee members, technical team led by Mr. Ganesh, especially for ensuring that unlike some monitors in the OT, nothing got disconnected today, except minor glitches. Special thank you to our MMC coordinator, Miss Leena, who helped us in getting approval of one MMC point. And because learning feels even better when it comes to points attached to it. So thank you, Leena, for that. And finally, I thank all the delegates for your active participation. That proves that ISA Thane academics are very much fully charged and not on battery saving mode. Thank you all the delegates, thank you speakers, thank you moderators, thank you all the organizing committee members, and Thank you all. Stay updated, stay confident, and may all your devices cooperate and all your cases go smoothly. Before I conclude, I will just, there is an important announcement Dr. Sonali will do. Sonali?
Yeah. So, as you know, we are organizing MassCon 2026 this year. It will be at the Aurika group of Aurika Hotel, which is near the airport on 24th and 25th of October 2026. So I invite you all for this 2 days of packed academics, and the flyers will be out soon. So just to keep yourself updated, it will be posted on all the groups. The workshops are almost monthly on one Sunday each month and spaced over at different hospitals all across Mumbai and Thane. So let me take this opportunity to announce a workshop, airway workshop at Jupiter Hospital on 12th of July. So all kindly please make a note and register as soon as the flyers come out. Thank you, Yatin, for giving me this opportunity to speak on behalf of MassCon.
Thank you, Sonali. We now formally conclude our session. Thank you all and have a wonderful evening. Thank you.
Thank you, sir. Thank you,
Thank
ma'am.
you, sir.
Thank you. Thank you.
Thank you. ISA Thane, excellent CME. I missed the first lecture because of the simultaneous cultural program, but the last two talks were excellent, and even Prajakta's I heard from half the talk, and so much detail. It's much eye-opening rather, and we take it very casually, especially the cochlear implant. And Dr. Samrat, the pacemaker talk was so beautiful. I felt like a PG student listening from A to Z. It was really good. And Jana sir, खूपच छान. Thank you so much. Thank you. Thank you, ISA Thane, for this webinar. Manisha madam, and Yatin sir, and Sonali, and Ajay Yapa. Yeah, so very nice. Thank you so much.
Thank you, Dr.
Thank you, thank you, thank you.
Thank you, ma'am. Thank you.
Thank you, thank you, thank you. Thank you, bye.
Parna and Nilima, who could not attend, we are missing you all.
Yeah.
Yeah. Sure.
Thank
Thank
you.
you. Yeah. Good night.
Good night,
Good night.
everybody.
Have a wonderful evening.
Thank you, everybody. Thank you.
Bye. Bye.
Thank you.